we can start with the session. They will come later on because we have a lot of online people waiting for our sessions to start. So I announce opening the event with all your permissions. Thank you. So good afternoon, ladies and gentlemen, and welcome to beautiful Goa, first of all. It is my absolute pleasure to be your host for the next 3 days for our seventh edition of CUBE ECTC 2024 and the second edition of SFCC 2024, brought to you by Mindray India in collaboration with BLK Max Super Specialty Hospital, ACC LMP Con, and IFCC. We are excited to have some of our brightest minds in the fields of pathology, hematology, and in vitro diagnostics here with us today. We are we have an exciting lineup of speakers and sessions over the next 3 days. It's overwhelming, and like we are looking forward to engaging discussions and sharing knowledge. Before we dive into this program, I would like to take this moment to express our gratitude to our partners and sponsors who have made this event possible. A warm welcome to all our esteemed guests, speakers, and our online delegates. We are honored to have such a distinguished group of pathologists, hematologists, and IVD fraternity gathered here. Let's all extend a heartfelt thanks to all our channel partners and industry collaborators whose unwavering support has been instrumental in organizing all this. Without further ado, a kickstart of this prestigious event, we are privileged to have with us all the eminent speakers here. To start with, may I call on stage Dr. Tajinder Singh, Dr. Anil Handu, Dr. Sukesh Nair, Dr. Ajay Shah, Dr. Ramon Simon, and Dr. Ashwini Sengupta for the lamp lighting, please. Lamp का ये है. Lamp का ये है. We want to. Tell the boys. You have to escort him. Lighting the lamps symbolizes the dispelling of darkness and beginning of knowledge and enlightenment, which are the very pillars of this event. Let's give them a warm round of applause. Thank you, esteemed dignitaries, for illuminating the path of this event with the symbolic lighting of the lamp. Let this ceremony serve as an inspiration as we embark on the 3 days of knowledge sharing, collaboration, and innovation. Sir, sir, sir. I would request everyone to please stay on stage for a photograph moment, please. So this is memorable. Nikhil, Mr. Tejinder Singh. So we start with our day by welcoming on stage our next, our first speaker, our keynote speaker, our guest of honor. Actually, prior to that, I would like Mr. Bob, who is the regional marketing manager for India, to welcome our audience. Welcome, Bob, to the dais, please. Yeah, it's you. Where
You
is
pay
it?
the laptop? Oh,
You want to laptop?
yeah. It's okay. It's okay. It's okay. No problem. Shama, I can do. Thank you. It's okay. It's okay. No problem. Thank you, Shama. Thank you, the team. And good afternoon. And dear Dr. Anihandu and Dr. Lopez and our honorable chairpersons and our esteemed speakers and our distinguished guests from around the world. On behalf of Mindray, I will delighted to welcome you to 7th Cube here and the beautiful Hyatt and Goa, India. And first, I would like to express my heartfelt thanks to all of you for being here. And your time and the dedication are super valuable. And we truly appreciate your participation. And I would also like to acknowledge our Mindray team for their commitment in bringing this event together. So for over 20 years, Mindray has privilege of working closely with the Hematology Clinical Society of India, and our collaboration has played a key role in advancing hematology diagnostic in this great country. And we are honored to continue this journey with all of you. And CUBE, ECTC 2024 highlights the convergence of hematology technologies and emphasizing how we can deliver more value to clinician and the patient. and it reflects on our commitment in improving diagnostic accuracy, efficiency, and patient care. And at Mindray, we believe our role goes beyond developing tools. We aim to improve, enable, empower doctor to make faster and better decision and to improve patient outcome. So every advancement we make today is driven by only one purpose: to enhance quality and accessibility of diagnostic, and whether enabling earlier detection or streamlining treatment path. I think our goal is to improve care experience for both doctor and the patient. So these 2 days are about sharing knowledge and the insight. I'm confident that we together can push our boundary of what's possible in diagnostic and also contribute to better healthcare to everyone. So once again, thank you very much for being with us. And I look forward for meaningful discussion ahead. And here is to successful and inspiring event. Thank you very much.
Thank you very much, Bob. And without further ado, since it's already late, our session has started already late by half an hour. We start with the session of our honorable guest of honor, Dr. Tejinder Singh. And may I request Chirag to escort Dr. Tejinder Singh, please? That's a legendary moment, sir. And we want a photograph. Thank you so much, sir. So we commence today's session with a legendary talk by our guest of honor. Thank you. Thank you, sir.
Good afternoon, everybody. I'm really grateful to Mindray and BLK Max, especially the director of BLK Max, Professor Handu, Sukesh Nair, Professor Raymond, Ms. Shama, Mr. Mukherjee, and Mr. Bob for this honor which they have bestowed upon me. We all know that hematology is sort of a new subject. It is something not very, very old. So what I'm going to do in these 10-15 minutes is give you a brief history of hematology, how the cell counters have evolved in last few years, and finally, what is the future of technology. Mindray, Coulter are some of the companies who have done tremendously good amount of research for improving the cell counters. And many other companies are following them, resulting in few better options. So what I'm going to do is give you just brief glimpse of what is going on. This is just started. Okay.
You want the access from here or there?
Okay.
If you want, sir, we can start it from here also.
No, I'll do with this.
And you can see here, sir, if you want.
Huh?
Or I can start it here also. You can see from there.
No, it's okay. That's it. I think stop. See, hematology is study of blood. And when did it start? It started with Leeuwenhoek's discovery of the blood cells way back in 1674. And then the discipline of hematology has been brought in. Then came Professor Workhouse, whom we call as father of cellular pathology. And he was the first one to recognize that in certain diseases, which were labeled as leukemia, that the white cells proliferate tremendously. And then came the legendary Professor Maxwell Winthrop. Professor Winthrop was a medical student at University of Manitoba. Then he started as an assistant professor in medicine. He was in the Department of Medicine. But people recognized certain diseases, and his professor told him that they are holding a conference, and in that conference, he has to handle the cases where there is hematology component. He took an interest, and what happened? He became interested in hematology. Once he became interested in hematology, he realized that there are no quantitative measurement of the cells as such. So he went on to discover what we now call as Winthrop tube. And the Winthrop tube gave the hematocrit and the packed cell volume. And he was the first one, he said, that in certain anemias, the red cells are smaller, and in other conditions, they are larger. So he classified the red cells on the basis of size, normocytic, microcytic, macrocytic. And that is the concept of anemias which we follow till today. There have been tremendous research and advances in the field of hematology. Basically, there are more advances in therapy as compared to the advances in lab technology. In last 50 years, there have been two groups of diseases. One are those diseases which are involving the cells of blood, like white cells and red cells or platelets. Second are the diseases which do not involve the blood cells, but the diseases are reflected in the blood. So therefore, the analysis of the blood is most important in any disease, whatever it may be, whether a hematological disease or non-hematological disease. I'll give you an example, one example each of advances in clinical hematology and one incident of lab hematology. This is a 25 years old lady. She was admitted with PUO and spleen. You can see the peripheral smear, which is showing us immature white cells suggestive of CML, all of you know. That is a peripheral blood. And that is a bone marrow where you find 100% cellularity, and almost all the cells are the myeloid cells with hardly any erythroid precursors. Of course, megakaryocytes were also increased. Those days in 80s, we used to do KNAP score. And it was very, very useful. And in this particular case, the KNAP score was only 5. Again, highly suggestive of CML. PH chromosome was positive. There were very, very few centers where the chromosomal analysis used to be carried out those days. She was put on treatment. Myleran we used to give. 2.5 years she got it. And then somehow she stopped responding to Myleran. Hydroxyurea had just come in at that point of time. So she was put on hydroxyurea. She was doing pretty well. And one day she came to the clinic and she said she wants to get married. We were all surprised because we had told her many times what is the prognosis, how CML behaves, how it changes into a blast crisis. And once a patient comes into a blast crisis, it is very, very difficult to treat. Yet she said that she wants to get married. Then after a month, she brought her boyfriend who was ready to marry her, knowing very well the complications which she is likely to have. And she got married to that boy. And a year later, she had a baby. During the course of her pregnancy, as the God was with her, we found her TLC never increased beyond 20,000. It remained between 10 and 20,000. She delivered a normal baby. After that, her count started going up. And then, whatever was inevitable, as we had warned her, she developed a blast crisis and passed away. A few years later, the ammunition against CML was available, and that is imatinib. These are the bullets which came, and that is where a saga of targeted therapy started. I wish at that time we had imatinib available. Probably we could have saved her. So I feel that it is one of the major discoveries in hematology of targeted therapy, which started with CML. And now we have so many of these targeted therapy, which includes rituximab and so many other drugs, which just go and hit the target. Then now we have for BCR-ABL, anti-BCR-ABL, TKI, what we call them. Now we have not only imatinib, we have dasatinib, nilotinib, and so many other drugs which are far better than even imatinib. Now, technology-wise, now BCR-ABL is not a qualitative test, it is a quantitative test. So it is being used not only for diagnosis, but it is also being used for monitoring the response. And then that is what, and when these patients go on to blast crisis, that's the time when we really have a problem in these cases. Now I go on to the advances in technology. I'll give you one advancement. Our physicist at MEMC, 63-year-old, was admitted with weakness, low-grade fever of 1 month duration, no organomegaly. X-rays showed osteoporosis, low hemoglobin of 10 grams, TLC, DLC normal, ESR was high, 67. And then ultrasonography normal. It turned out to be a dry tap. Since we were trying bone marrow aspirate, and then we did bone marrow refined biopsy and made the imprint smears. And this is what we got in the bone marrow refined biopsy, a pleomorphic tumor, appeared to be a carcinoma, undifferentiated carcinoma, anaplastic carcinoma, and along with it, there was fibrosis in the marrow. Since there was fibrosis in the marrow, that is why we got a dry tap. These are the imprint smears. We couldn't make out from the imprint smears what type of cancer is it. He rang up in the evening and asked, have you seen the Jamesa smears? We said, yes. He said, what is it? I said, it appears to be an anaplastic carcinoma. So he said, but he doesn't have symptoms of any other organ as of now. We kept on examining the smears, and then we found there was an occasional plasma cell which was seen amongst these anaplastic cells. And then we thought, could it be multiple myeloma? But then how to prove that this patient had multiple myeloma? And then we had these markers available, immunohistochemistry, a simple test, but this technology of immunohistochemistry, the specific monoclonal antibody, has changed the paradigm of diagnosis of cancer. Now, whether it is a multiple myeloma, whether it is acute leukemia, chronic leukemia, any malignancy, any type of malignancy, you can apply these markers, and these are being applied every day, whether it is breast cancer, whether it is prostate cancer, and we are able to diagnose a particular disease. So in this case, anaplastic tumor turned out to be a multiple myeloma, which was CD138 positive, kappa negative, only lambda positive was seen. So all the cases of dry tap, nowadays, from that day onwards, we always do immunohistochemistry. maybe for acute leukemia, maybe for multiple myeloma, and sometimes for metastatic carcinoma, because in the fibrous tissue, the tumor cells are trapped. You can't make out the morphology, what is it? And that is where the immunohistochemistry comes handy. Not only that, now we have got markers which do the molecular testing also. Say, for example, BRAF, we have got now the markers available. For PML-RARA, we have got the markers available. So not only we can make a diagnosis, but give a molecular diagnosis also with immunohistochemistry. So there have been so many advances in technology also with the result that there is accuracy, increased efficiency, and the costs have reduced. And moreover, not only all these things lead to a better patient outcome. Automation of laboratory analyzers have just changed it. I remember as a postgraduate student, I used to sit in the evening and do the TLCs and the platelet count. After doing the TLCs and the platelet counts, then only we could see the peripheral smears or we could see the bone marrow smears. And sometimes there used to be 20 to 30 platelet counts. So till we finished those platelet counts, we could not see the peripheral smears. That was the time we always wished that there was cell counters available, and then these workflow, these cell counters came in. Now we know that there have been so many advancements in these cell counters, and the latest one is monocytic changes in the white cells, which is an indicator of septicemia. Now, there was a time we were looking for immature granulocytes in the cell counters, in the blood. And therefore, you will find that many of these instruments, they gave immature granulocytes, like which would pick up band forms, metamyelocytes, myelocytes, and that used to be an indicator that patient is going to septicemia. But now we know that before the immature granulocytes appear, it is a monocytes which swell up, which may show vacuoles, as I've shown on the right side. And these are the cells. If you find them, patient has fever, other symptoms of septicemia, it is likely to be a case of septicemia. So nowadays, for pediatric ICUs and even for adults, now this is being taken as an indicator of early septicemia. So what is the number of the monocytes? It is not the number of the monocytes which is important. It is the qualitative changes in the monocytes, as a result of which there is a MDW, that is monocyte distribution width. If you find it more than 20, it is highly suggestive of septicemia. So institute a therapy for septicemia immediately. What about the microtechnology? Now we are having, we want that instrument should be small, it should be perfect, it should be accurate, reports should be precise. So now we have got microtechnology, and we have microfluidic devices such as lab on chip. We have micro total analysis system, and there are micro channels or nano channels which allow for the integration of various multiple laboratory processes. That means all these laboratory processes are taken care of in a tiny chip, and these instruments have become very small. And these chips are made on silicon, glass, ceramics. So the technology is so advanced that small machines will give you hundreds of tests simultaneously, the results will be available. And similarly, that is why the microfluidics have come into play, and as a result of which we are able to now give DNA sequencing, cell sorting, and immunoassays. Now, these have been applied during the COVID times, and the newer instruments are based on microtechnology and microfluidics. Because of that, point of care testing instruments have come. Suppose for a person we want to do prothrombin time, or we want to do cell counts, or you want to do biochemical analysis. Now these point of care testing, they are being based on this micro technology. And now we have lab on a chip. That means in a lab, the biochemical analysis, the cell counter analysis, everything is being controlled by a small chip. And the instruments are becoming small. And now the whole lab, all the functions in the labs are being controlled by a small chip. Now, why not there have been advances in histopathology or hematopathology? It has not been possible earlier, but now we have everything available, because what is required for histopathology and hematopathology is, number one, digital imaging. Number two, we need artificial intelligence. Third is machine learning. And fourth is integration with the lab system. Earlier, it was not possible, but in last 5 years, we could do the digital imaging of histopathology samples. We could do it for the peripheral smear, and machine learning is there, and their integration with the list system is also possible. So what do we have in digital pathology? We take the sections, take multiple pictures. So what do we do with those pictures? Number one, what we need are the scanners. Now we have got very good scanners available. The pictures are just beautiful. They can show you the nucleus, nucleolus, the chromatin pattern, and everything. Second thing is, it has improved the diagnostic accuracy, and then we can store the material. Now we need not store the slides. We just store the images in the cloud. So that is what has happened. And third is, it has facilitated the use of artificial intelligence and machine learning. That is, we have made a database of millions of images, and then the computer picks, and suppose we have got a slide, we feed those pictures into the computer. Computer picks up the similar pictures and tells us that this is a prostate carcinoma or squamous cell type or whatever it is. So with the use of artificial intelligence, machine learning, we are able to diagnose a disease based on the databases which we have already made. So the digital pathology has come in a big way. So we have scanner, we have the slides, then we have the images, and then we can have a consultation. Not only sitting in Delhi, but we can just send the images across any part of the world, and we can have discussion on any particular case. Why do we need all these machines? Why do we need so many drugs? Why are we investing billions of dollars in healthcare sector? So that people remain healthy, number one. Number two, if they fall ill, we make an attempt by giving the drugs based on the diagnosis. And the diagnosis is based on what the results are given by the machines. So arose a concept of a functional health. Now, the central purpose of the healthcare in our world is that the people maintain or regain functional health if they had fallen ill. So what is needed for all these? For functional health, we need diagnostic tests. Not only for diagnosis, but for screening and monitoring, so as to prevent a premature death and maintain the functional health of the population. So the impact of a diagnostic test is to cope with their illness and give a quality of life to the patient. So now we should have additional diagnostic testing so that ineffective treatment may not be given to any person. Unnecessary financial burden should not fall on the patient. So for introduction of a new test, what do we need? We need clinical utility. Now that is where the concept of a clinical utility came in. Now what is needed is that any test which we are going to start or which we are already having is should have a clinical utility. Now the innovators, developers and manufacturers, they identify why we are making this test. They should know what is the use of this test. Do they have a positive impact on the health outcome or not? Earlier, this concept of clinical utility was not there. We would just create a test and give it to everybody that this is a test available. Now you get it done. But now what we want is what is the health outcome over a period of time if we do this test and the test comes out to be positive or negative. Now, we have got a machine from Mindray, say BC 6200. What test does it give? It picks up the immature granulocytes. It picks up the atypical cells like blast and atypical lymphoid cells. It gives information even about malarial parasite, malaria. It picks up the band and nucleated RBCs, atypical lymphocytes, metamyelocytes, myelocytes, and even immature basophils. Does it have any clinical utility? Yes, because all these tests are used not only for diagnosis of a disease, but also for monitoring of the disease and then treatment of the disease. Say, for example, immature reticulocyte fraction. We have a talk on IRF also. What does it indicate? It indicates you have done a bone marrow transplantation. Has the marrow grafted? There should be some parameter. IRF is one of them. You have given chemotherapy. After chemotherapy, the hemopoietic cells have disappeared, but the hemopoietic recovery has started. How will you know the recovery has started? This is one of the tests. IRF will give us an idea. Yes, the hemopoietic recovery has started. Similarly, in CRF, you give EPO. Subcutaneous EPO is given to the patients, but has it really responded or not? So one of the parameters is again IRF. So therefore, such tests which are giving not only diagnosis, but also keeping a tag on the health of the patient and ultimate outcome is positive. All those things should be there in a test. Monocyte changes as a marker of septicemia is another one. Now, these are all very, very useful tests, I said. So all these tests are of high clinical utility. So that is where the concept of high clinical utility came in. So what is a clinical utility? Clinical utility refers to the usefulness of a test in clinical practice. We have to weigh the benefits and risks, and then we have to see, does it cause improved health outcome at the end or not? If it does, it has got a high clinical utility. Otherwise, it has not. Say, for example, there is an example that ESR is done every day. But what we find is it does not correlate with the disease. It does not diagnose a disease. It is not an indicator of response to the treatment. It has got poor clinical utility. So the tests which have got poor clinical utility should not be carried out because that is a burden on the patient itself. So when do we say that it is of high clinical utility? If there is a treatment response, if we know that it will give us potential adverse events or complications information, or it will optimize the healthcare resource utilization, and it will improve the patient outcome, then we say that this is a test of high clinical utility. Rather, now all the developers, the companies should make a test which is of high clinical utility. Similarly, say bone marrow differential count. Now, this is a challenge. This is a challenge for all the developers who have been using artificial intelligence, machine learning, and the digital pathology. We are giving now machines are available, softwares are available where you do it on peripheral smear. But the bone marrow differential count has been a challenge so far. So that is, I feel, is an emerging technology. If we can do that successfully, it is going to help the patient, the diagnosis, the treatment, And therefore, what is needed is a high resolution scanning. Now, some of the studies have come who have scanned the slides at 100x. Earlier, most of the cases, the scanning was at 10x, but now we have got at 100x, so that you have got each cell morphology very, very clearly. Now we have the artificial intelligence models also. We have made the data sets of these various images. Now this is the system now we have got. This is the scanner. These are the images. Then these images are analyzed, and the same technology which was used for histopathology is now being used for bone marrow. Where is the problem? The problem is that the staining is not uniform. In my lab, staining is more bluish. In Sukesh Naik's lab, it is more eosinophilic. And at Dr. Handu's lab, what I find is that it is neither acidic nor basic color. It is the neutral color which comes. So if we have thousands of images of the bluish ones, the red ones, or the neutral ones, then these may not be able to be picked up and the wrong diagnosis will be given. So we have to optimize the staining. And another challenge is that the bone marrow aspirate smears are not uniformly thick. Some areas of the smears are very thick, some areas are very, very thin. So therefore, all those factors have to be taken into account. But in last 2-3 years, there have been so many studies. Most of them are published in Blood, like digital AI in hematology, integration of 100x scanner with newly implemented AI capabilities. Another one is a completely digital workflow for differential in the bone marrow morphology. These are all pilot projects, but they have done successfully, like scanning at high resolution and then applying machine learning as well as artificial intelligence. And then we have a fully automated digital workflow where they are working. Another problem is storage space and the scanning time. The scanners take a very long time to scan a bone marrow smears. If you've got ever done, it may take 2 to 3 hours. Number one, because the smears are very, very large and you are doing at a high resolution. It takes very, very long, unlike a histopathology slide. Now, this is one study where they have shown the green squares and there are red squares. Green squares are what we have seen with our own eyes, microscopy result. We have labeled each cell as myelo, meta, early, intermediate, normoblast. Then the red ones are the ones which are counting done by the machine. So that is what is given. And then they have given that which one is more accurate. Of course, the microscopy picture is the main thing on the basis of which you say that the accuracy is 90% or 95%. But in these pilot projects, they've got pretty good results. But then another study came again in Blood. This is deep learning predicts therapy relevant genetics in AML from Pappenheim stain bone marrow smears. What is Pappenheim stain? It is one of those Leishman stain or Ginger stain like. So what they have done, they have taken pictures of the nuclei of AML cases. Just on the basis of those pictures, they've said that it has got T1114, it has got T69, or it has got 1419 transformation or inversion 16 just on the basis of microscopic picture. That means you don't need these expensive tests. You don't need these expensive tests or molecular or cytogenetics. This will give you as much information as you will get after doing the molecular testing. So why not go for this? And now, if this comes out to be true, I think it will be a boon for all of us, that based on the pictures and then the machine learning and artificial intelligence, we will be able to tell whether it is which type of AML based on these photographs. Now, with all these innovations, what do we expect now? Next big achievement in the field is going to be probably the application of genomics and personalized medicine is going to continue to evolve and have a greater impact on hematologic malignancies. And then as far as treatment is concerned, it appears that immunotherapy potential is great. Now we are seeing the CAR T cells which came for multiple myeloma are now being applied for lymphoproliferative disorders and even for ALL also. So I'll end with that statement. The gold standard of treatment of hemat disorders is diagnosis by hematologists, which takes into account results of additional tests as well. And Kravitz says, the point of using artificial intelligence is not to replace the physicians. Now, don't think that the pathologists will become villa. They will have no work because everything will be done by the machines. No, that will not happen. The point of using artificial intelligence is not to replace the physicians, but to make the best use of information which is contained in the data. So that means it has to be something very, very judiciously. The master is the pathologist. That part will always remain. Thank you very much.
Thank you so much, Dr. Tejinder Singh. May I please request Dr. Sukesh Nair to hand over the memento to Dr. Tejinder Singh, please? Thank you so much. Two legendaries. A photo moment. Thank you. Thank you, Dr. Sukesh Nair. Thank you, Dr. Tejinder Singh. So we start with the session post lunch. I hope the lunch was good. Thank you. May I request Dr. Anil Handu to chair the session, please? CV laga.
So it's my immense pleasure to introduce a dear friend and, of course, an astute pathologist who runs a center for pathology in Delhi by name Dr. Suri Path Lab, second generation pathology laboratory in Delhi. They have, in fact, supported us also in our hospital when we started in 2007. And Dr. Suri, can we just go back? You. Yeah. So he's an alumnus of Maulana Azad Medical College, both his MBBS and MD, and his expertise on CVC, especially the analyzer science, has been pretty significant. In fact, he's been awarded at multiple conferences for his commendable work, which they did on platelets. And I think you're again talking about that today. And we will be hopefully getting some new insights. Over to you, Dr. Suri. Thank you.
Thanks, Dr. Anil, for your kind words. At the outset, I'd like to thank Mindray India Limited and BLK Hospital for giving me this privilege to present in front of this August gathering. And we've done a lot of work on dengue. A lot of lectures that I've taken over the years. It's kind of a summation of all the papers that we have presented so far. So the title is Predictive Markers in Dengue, the Journey So Far. So we all know that basic principle of all hematology analyzers is fluorescent flow cytometry, where the forward scatter of the light is depictive of the cell volume or the cell size, which means the more the forward scatter, the bigger is the cell. Side scatter is showing the internal cell structure or the granularity. which means that the higher the side scatter, the more granular is the cell, and the side fluorescence light, which is telling about the RNA and DNA content of the cell. So the more the fluorescence, the more immature the cell and more the RNA and DNA content. So all of us who are using Mindray analyzer are familiar with this technology SFQ. I'll just briefly describe it because I want to enumerate a particular cell line as a predictive marker. So this cell line here, the green is the lymphocyte, which is kind of having moderate cell size, but is low on both side scatter and fluorescence because there is no granularity. Just ahead of the lymphocyte is the monocytic population in pink, which is larger in size than the lymphocyte, but again is low on the side scatter and fluorescence. In the middle here is the neutrophil and basophil area, which is higher on the side scatter because of granularity. And to the extreme right is the eosinophilic area, which has got the maximum side scatter because of the large granules. And this is the area of interest for which I'm showing this cube. This area, the small green dots above the pink one are the area of the HFC or the high fluorescence cells. So this has got a lot of prognostic significance in dengue, and these are nothing but your downy cells, virocytes, transformed lymphocytes, call them what you may. Now we can give them a number, we can establish a biological reference interval for these virocytes, and they have a prognostic role in dengue. So the rest of the cell lines are not important for the current presentation, so I'll skip them. So first, coming to immature platelet fraction, this was the first parameter that gained traction as a prognostic marker for recovery of platelets in thrombocytopenic dengue patients. So as we all know, the high ITP is suggestive of hyperactive bone marrow when there is peripheral platelet destruction in conditions like ITP and dengue. And of course, low IPF is seen in conditions when there is bone marrow suppression like hypoplasia and aplasia. So this is the platelet scattergram as comes out of the Mindray analyzer. This turquoise blue and the green area together is the area of the platelet scatter. And on the y-axis is the forward scatter or the cell size, and on the x-axis is the fluorescence. So this shaded green area is the area of the IPF. So these platelets are not only having high RNA content or are reticulated, but also include a significant proportion of the giant platelets. So IPF is not only reticulated platelet, but you can say it is a summation of both giant as well as reticulated platelets. And this has some significance when you are looking at ethnic considerations of IPF, especially from patients coming out of East India. So I'm just showing a brief prototype case history how the IPF works in platelet prognosis. This is a 56-year-old lady with fever for 3 days, NS1 positive. So this is day 3, platelet count is 171, IPF is 4.5, our normal range is up to 6.6. This is the platelet histogram, perfectly normal, scattergram is fine, the greenish dots are less in number. Day 4, platelet count has reduced to 82, IPF has jumped up to 8.9. Again, platelet histogram a little distorted, but not that bad. You can look at the IPF scatter, it is showing more density now than the previous slide. Day 5, platelet count further reduced 57,000, IPF is 10.4. Again, the histogram and scattergram for the same patient. Day 6, platelet count has further reduced to 42, but now the IPF has also reduced. So day 5 was the day when we attained peak IPF values, because from that point onwards, IPF is again begin to dip. So day 5 is an important day in this case. Same histograms and scattergram for the same patient. Now this is day 7. Now the platelet count has recovered and the IPF is still decreasing. So from day 5 to day 7 is 48 hours. So most of the patients in whom we attain peak IPF, usually a platelet recovery happens within 48 to 72 hours. So it's a useful parameter, especially when patients are paranoid, both clinicians are paranoid for admissions, transfusions in a resource crunch setting in Delhi. So again, histogram and scattergram from the same patient. So this is how the correlation goes like. The green dot is the IPF and blue is the platelet. So after peak IPF is attained, the platelet recovery usually takes about 48 to 72 hours. So this was our first paper that we presented in AIIMS in 2015. It was called Peak Immature Platelet Fraction as a predictive marker of platelet recovery in dengue patients. So the objectives were simple. We were trying to establish IPF as a prognostic marker. and see that, within what defined period from peak IPF platelet recovery happens. So we use a simple 4-step methodology. First, we took NS1 antigen or IgM positive dengue patients, then only reduced to patients who were thrombocytopenic, removed all other patients. Then we took patients who had both rising and falling titers, so we could establish the peak IPF for each one of our patients. And then finally, the optical platelets and time to platelet recovery was monitored on a daily basis for all of these patients. We also established the biological reference interval, did precision study, did smear validation for all the patients. So these are the results. First, peak IPF values of patients range from 5.5 to 38.7 with a mean of 13.5 and standard deviation 6.4. Which means that we could not set a ballpark figure to IPF. IPF had to be followed like a trend analysis because each patient will have a different peak IPF value. Secondly, 86% of our patients whose peak IPF of more than 20% were ethnically from West Bengal and Bihar, typically the Harris platelet syndrome belt. So later on, this had some use in other studies when they tried to establish the IPF normal ranges from Eastern India, which were roughly 2 to 3 times those that are there in Northern India. 100% patients showed platelet recovery and 86% within 72 hours. And peak IPF had a strong correlation with time to platelet recovery. So as they say, you are first time lucky. We got the first prize for this paper in 2015. Then we presented another paper next year where we were trying to compare IPF across different platforms, although not related to this study. Where also we managed to bag a prize. Then this is the next important parameter, high fluorescence cells or the HFC that I showed in the SF cube. So these are nothing but your large lymphocytes and typically your downy cells or your virocytes, whatever. So we have established a normal range for these now. On our analyzer, it is up to 0.4. So this is again, I'm showing a prototype patient. This is dengue NS1 positive patient, day 4 of fever. We are beginning from day 4 because HFC usually begins to rise from day 4. The first 3 days, HFC is perfectly normal. Because as dengue progresses from relative neutrophilia to relative lymphocytosis, the evolution of HFC begins roughly from around day 4. So on day 4, this platelet count of this patient was 91,000 and the HFC was 0.6%. So these small tiny green dots here, these are the HFC, very few dots here. This is depicting the HFC. Same patient, day 5, platelet count went down to 58,000, HFC jumped up to 7.7%. So between day 4 and day 5, there is a 10-fold jump in HFC. So this is important. The jump of HFC is important in the prognosis of dengue. So again, you can look at the scatter plot. This HFC area is now having much more density than the previous day. Day 6, platelet further decreased to 53, HFC moved to 15.3. The jump was only two times the previous day. The maximum jump happened on day 5. Again, the scatter plot from the same patient. Day 7, platelet further reduced to 41,000, HFC jumped to 19.9. Again, scatter plot histogram from the same patient. Now this is day 8. Now the platelet has recovered to 54 and the HFC has gone down to 15.2. So the time the HFC goes down is roughly the same time that the platelet moves up. So this is not an important time. The important time is the jump. We followed it for another day. Day 9, platelet further went up, HFC reduced to 4.9. So what I want to say here is that HFC increases from day 4 of onset of fever in dengue patients, and platelet recovery happens in HFC again within 48 to 72 hours from the HFC jump of 3 to 4 times. Like it happens within 48 to 72 hours from the peak IPF. So HFC is also a good prognostic marker of platelet recovery, just like IPF. And we found our own algorithm that kind of works well in all dengue season or the post-monsoon season in Delhi. A febrile patient in monsoon season with a platelet count less than 50,000, IPF more than 20% and HFC more than 5% is almost certainly dengue, even irrespective of the serological status. That is important. Because even in a serological status, there is a blind window. The NS1 is 95% positive only for the first 4 days. 5th day, the sensitivity drops to 65%, 6th day, it drops to 35%. And these antibodies sometimes take day 7 to come. This 5th and 6th day of dengue could be such where both antigen and antibody could be negative and patient could still be dengue. This algorithm is a giveaway. We ask the patient to repeat antibody after 48 hours and it invariably becomes positive. So this is the third paper that we did in 2019 in ISLH. Here what we did was we evaluated all the predictive markers and tried to see which one is the best amongst them all. So what we did here was, again, same 4-step. We took dengue patients, ruled out patients who were only thrombocytopenic, took the criteria rising, falling titers, took the HFC jumps. And these are the parameters that we measured. Mean platelet volume, immature platelet fraction, high fluorescence IPF, HFCs, neutrophil lymphocyte ratio, platelet lymphocyte ratio, and last but not the least, platelet HFC ratio. So we were trying to see amongst all these plethora of prognostic markers, which is going to give us the best results. So these are the results. As you can see, this is IPF, HFC slightly outperforming the IPF, but the best performance was coming from the platelet HFC ratio, and it was natural to happen because as the platelets are decreasing, HFC is increasing. So when the numerator is decreasing and the denominator is increasing, the intraday falls would have an augmentational effect. That is why PHR performed the best amongst all these markers. And among the fall and jump markers, again PHR fall, which is an intraday, fall of more than 50%. PHR fall was the best predictive marker. So we could establish the clinical utility of all the markers, and PHR fall was the most efficacious markers amongst all the parameters that we had analyzed. So with these words, this is what we presented at ISLH Vancouver. This is the panoramic view of the city of Vancouver. With these words, I'd like to thank you all. If there are any questions, I'll be glad to answer.
Thank you, Dr. Suri. That was really eloquent and very nicely presented. Any questions, anybody?
Dr. Sukesh. Dr. M.
Thank you.
It's not a question, it's just a confirmation because you did the studies before. But just to tell you that in 2024, in the ISLH meeting in Nantes, in France, Dr. Marcone from Argentina, is one of the countries with much more number of dengue. And the last year, they have 230 patients dying of dengue. They say that the dengue now is much more aggressive than before, because in 2023, they have only 20 deaths because dengue. They did a study in pediatric samples, and they found the same than you now in 2024, that the IPF was coming higher, they say more than 8, before the severe dengue, hemorrhagic dengue. And that is important because maybe with your results and confirming pediatric samples, we can do something else before it happens. I don't know because I am not a pediatrician or an expert in the treatment of dengue, but if something can be done to avoid the cytokine storm or whatever provokes the thrombopenia and the hemorrhagic dengue can be done when IPF is more than, and I agree with you, every patient has its own values. It's more important to follow up the patient, not the cutoffs, and to see that one day IPF goes up, and in this moment, pay attention, because maybe you have to do something else to avoid. And congratulations for your presentation.
Thank you. Dr. Sukesh.
Thank you.
Dr. Suri has been chasing dengue for a long time. I think commendable effort for all the work that you have done. But I am talking about a parent who has got a child whose platelet count is less than 10,000. 48 hours to 72 hours is 2 to 3 days away. How can you reassure a parent that IPF बढ़ रहा है, platelet आएगा 2 to 3 days later? So 48 to 72 hours is sometimes very difficult to convince a parent who has got a child who is not parent, anybody, even a wife or a husband, that platelet count is less than 10,000. Huh?
Even the pediatrician, sir.
Yeah. And thing is, in Malaysia, isolated platelet transfusion in a patient with thrombocytopenia and dengue, you are put behind the bars. In Malaysia, if you transfuse platelets in dengue, you are put behind the bars.
At any count, sir.
At any counts. At any counts, you are put behind the bars because they know that isolated platelet transfusion in dengue is a killer because it enhances end organ damage. So 48 to 72 hours is not a good criteria. And the other thing which you mentioned is that HFC, they're not lymphocytes. Unfortunately, Tina is here. So I told Tina many years back that they're not lymphocytes, they're monocytes. So that's why if you look at the way the lymphocyte, normally a reactive lymphocyte, the pattern will go like this. Here, the pattern is going straight up.
Straight up, sir.
It's going along the monocyte
Yes.
pathway. So they are actually monocytes which are infected with the dengue virus because dengue virus is monocytotropic. It's not lymphocytotropic. So thing is, when you show reactive lymphocytes can react against viruses. But these are monocytes which are infected by the dengue virus. And the dengue virus, because it's an RNA stain, it's a dengue virus which is in the monocytes, that's why the pattern is like that.
Yes, sir. It's like
It's not like the reactive lymphocyte pattern. So the pattern of hourglass is because of the monocytes getting infected by the virus. Raymond can make up.
Raymond wants to say something.
Let me make a comment about what are high fluorescent cells, because I am doing a lot of evaluations, and what I know is the instruments that use any way to detect peroxidase by Sudan black or by peroxidase. They originally were having a special stain for the monocytes. They were using, a special cytochemistry reaction, non-specific esterases for like the Technicon in that time, H6000. Okay, because the size they were reducing to the H1 and they were using only peroxidase, but they had a problem that many times the monocytes become look or unstained cells, because not using any technology, just the volume and the peroxidase, the monocytes become look or lymphocytes, but they are not, and as much mature as much. For this reason, I know every parameter have errors. Blast can be in the high fluorescent cells, but not in the Mindray technology. When high fluorescent cells, the more probable, except a leukemia, is that there are reactive lymphocytes, hyperbasophilic lymphocytes. No, I can prove that.
Sir, whatever they might be, but
I think we'll leave it for the dinner. We'll decide at the dinner what we're going to do with them.
sir, whatever they might be, but it helps to assuage a patient from not taking a bed when he ought not to take it in dengue.
In 2022, and isolated platelet transfusion was given to me at Max Hospital. And I was in the ICU for 1.5 months after the transfusion because of the transfusion related acute injury that I had. And moreover, Pradeep, I don't know all these fancy markers, IPFs and whatever, but isn't just this the clinical course of the disease, that NS1, as soon as the antibodies start getting formed, day 5 is the typical watershed when NS1 goes down and the antibodies start getting formed, and platelets are the innocent bystanders. They get neutralized by the antibodies, and ultimately recovery happens in 2 to 3 days time, whether you do IPFs or not. This is the natural
No, sir.
course.
I'll tell you how it helps.
And how does it help in predicting the course of the disease? Platelet recovery is going to happen, and low platelets, we know in dengue hardly ever kill any patient. It's the dengue shock syndrome So the PCV is probably a much better marker
Yeah.
of
PCV is more important, no doubt.
more important in predicting the poor outcome of the disease.
No, sir.
Platelet recovery is anyway going to
sir.
happen. So
Two things, sir. A, when a patient is going down on a daily basis, by the time he reaches 40,000-30,000, he is going to take a bed somehow by hook or crook. He will need to call anybody, take any jack, he'll take a bed in a hospital. At this point, if you can convince the clinician and the patient that he is going to recover tomorrow, because you already know peak IPF has happened
I mean,
2
on
days
the
ago.
contrary, I was very skeptical of going to the hospital.
No,
It was
sir.
the doctors who took me to the
So
hospital
there
and
are,
put me in a
sir,
bed and gave
no,
me
sir.
bed
There are many patients in whom we have prevented admission. Secondly, sir, like you just said that in India, what is happening currently, contrary to what sir says, most corporate hospitals or any hospitals in Delhi are transfusing at 10,000. Correct me, Dr. Handu, if I'm wrong. That is the current protocol, that anything below 10,000, they are usually transfusing. The clinician will not even listen to us, sir. 15 पे भी कर रहे हैं, but नहीं, I know that, but
20 is the borderline.
No, but sir, at less than 10,000, virtually everybody is transfusing. So if somebody is at 12, 13, and you can say wait till evening, he is just recovery is round the corner. Many a time you can prevent a lot of transfusions.
I'm here to tell this tale. I should not have been, by all means, because I was all gone. I had pulmonary shutdown. I had multi-organ.
No, I understand, sir. So sometimes this helps to convince the clinician not to transfuse.
Less than 20 if it's hemorrhagic, any hemorrhagic symptom, even petechias, or 10,000 if it's no any hemorrhage. But it's not black and white, depending also of the clinical aspects of the patient.
More or less same protocol here.
I think we'll close the session with this question. Thank you, Dr. Pradeep, for the wonderful talk and the discussion thereafter. Thank you.
May I please request Dr. Anil Handu to come on stage and felicitate our speaker? Dr. Handu ka as chairperson. May I request Dr. Ramon Simon also to come on stage so we felicitate Dr. Handu, please, as a chairperson. Thank you. Thank you, everyone. So moving on to the next session, may I request Dr. Sukesh Nair introduce our next speaker.
Here. I thought there's a position in the stage. Okay. So start with an apology to Anil. I hate the first statement. The next speaker does not require any introduction. Of course, not in front of this audience, but generally, I don't know why people have to say that. Okay, there are some people who don't know you, and there are some people who would like to know you. So, okay. So to tell about Anil Handu, I'm not going to read anything that he's got here. Just to tell about Anil Handu is that I got to know Anil Handu when he was working with Dr. Sood in Gangaram Hospital. I heard about him. I've never met him. And then Dr. Sood was fairly my mentor in the field of quality assurance he forced me to volunteer for NABL. I didn't have any intention to work for NABL, but he forced me to help for NABL. And then I think Anil had some issues with Gangaram. Then he shifted from Gangaram to some other hospital, and then he joined Medanta Medicity. And from Medanta Medicity, he joined BL Kapoor Hospital, which was bang opposite Gangaram Hospital. And I think by the time Dr. Sood was also in Gangaram Hospital, was mainly in the form of an advisor. And Dr. Sood said, you know, the guy who you admire quite a lot, Dr. Anil Handu, he's joining as the head laboratory director of BL Kapoor Hospital. I said, what is wrong, sir? No, but you know, it's too early for him. I said, sir, he'll do a good job. So finally, Dr. Sood went and told Anil Handu, your mentee is very confident that you will do a good job in BL Kapoor Hospital. Hasn't he done a good job? Outside. That's his introduction.
Thank you very much, sir. That's really benevolent of you, but I don't know. I mean, Dr. Sood has also been pretty instrumental in making me what I am today. And yeah, probably there was a disagreement on that front, but I still feel that he was somebody who really made my career where I am today. But thank you very much, everyone. And I know we are in post-lunch session. I know we've had some discussion about this already by Professor Tejinder Singh. And, you know, we've already kind of listened to all of this. But what I've tried to do this time is not to give you any information as to what we have really done, but what is my wish list, you know, even today, you know, when we look at uh, hematology analyzer and what Dr. Sukesh likes to call hemocytomorphometer, when we look at that particular instrument today, we still have certain wishes which, again, are kind of coming true. So this is the place where I work, and I bring you warm regards from there. And of course, my team, we have some of them here as well. And I don't have any specific disclosures to make except for the fact that this is a Mindray platform on which I have kind of, you know, agreed to talk about this whole thing. So evolving paradigm of hemocytomorphometry from cell counts to morphology and now beyond, where that's why we've named or themed our conference today as ECTC. The concept was that we've added ESR to it, we've added CRP to it, and now it no longer remains just like a hematology analyzer. It's actually convergence of technologies which we've tried to do. And this is primarily because of the fact, because when we were kids, this is a poem which we would be, you know, kind of rehearsing all the time. And they would say if wishes were horses. And wishes today are getting true. There are a lot of things which have already come true. Now, in the last decade or so, in fact, sir has already mentioned to you that, you know, I was a consultant hematologist. I moved to become a director of the labs, and I'm still working as in such position. But a lot of things changed in the world in last decade or so. At a personal front and the official front, we moved from a typical burgundy color, which used to be the color of my presentations previously, to you know, more bluish and greenish and stuff like that. So that's the biggest transition which we have had in the last almost a decade or so. And this is where we were, and this is where we are today, you know, as far as the organization itself is concerned. And beyond that, also, there are a lot of things which have happened parallelly. And I'm sure all of you are kind of aware of that. I'm not sure how many of you know these two guys, these two gentlemen. Who were they? Any idea? Any guesses? Come on, nobody can forget them for the rest of their lives. They were the ones who gave you the so-called WhatsApp. All right, so these were the WhatsApp creators in the world. And of course, that's something which has become a part and parcel of our life, the encrypted information which goes across to all of us. And more important than that, let's forget about the, you know, the Facebook guys taking it over. But what's more important is how WhatsApp has changed our lives today. When I don't have access to digital morphology on a cloud-based system, I'm still able to get a, you know, a PDF of my morphology from the MC80 analyzer on my phone. And that's where things have changed, you know, how you have really evolved over the last decade or so. We've also evolved, that, as Dr. Tejinder has presented in his presentation also. There is NGS, which is the new kid on the block, and everybody wants to not only talk about it, but do it also. And of course, there are lots of new entities and new things which are coming up. Even the classification today for hematological malignancies has changed. We know 2022 book, which has just been launched in hard copy. Of course, it's exorbitantly expensive this time in double copies. Do you know how much it costs today? The maximum retail price is 18,000 bucks. It used to start at about 2,500 when I bought the last one. Now this time, with a full discount, you still have to buy it almost at about 12,500. So that's changed. So everything is becoming expensive. And at the same time, it's also important for us to realize the technology is moving forwards. We know we are in the era of digitization, especially in the last 4 years. That's what we've seen as a big transition post-COVID. So, we are at the kind of a junction between the past and the present, the future. And at that moment of time, we're all now looking at the sci-fi. This is something which we had kind of envisaged. When I was a kid, I would watch Star Trek and I would think this is all, rubbish. It can never happen in real world. But now we know it happens and things are happening. You saw the news just yesterday how those small little pages were blown up in Lebanon, right? So that's the kind of power what we're talking about technology today. And how can analyzers be far behind? So what I have done in my talk today is I've again gone back into the history a little bit. We'll again talk a little bit about the Coulter principle. We'll recap about that. We'll talk about a little bit about technologies, some analyzer common antiques which are available, and then we'll also try to make some more sense of the automated data which is coming out of the analyzers today. So if we talk about history, a lot of it has been spoken about by Dr. Tejinder Singh, so I'll really not spend a lot of time on it, but just look at it. From early 1900s, where you were just looking at cells, at small little particles, and because you were able to stain them under a microscope or under a Newber's chamber or whatever you were wanting to put it onto the microscope, to a Coulter instrument from where you were actually able to count the cells quickly. And then, of course, we talk about many part analyzers today. And we all moved from the classical macro world to the micro world. And of course, we cannot forget the man down there who was the one who was instrumental in giving us all this into a many part analyzer today. Again, I'm not getting into details of this because this is something which we already know. So where have we started? We've started way back from just the routine regular staining on a slide up to a hematology analyzer. And lots of things have still not changed. We're still kind of looking at manual versus automated. If you look at platelets, we're still wanting to see a manual count. In fact, we start getting requests for manual count. Why? Because we kept giving comments in our report saying, this has been checked manually or this has been done manually and stuff like that. So people have really, really gone into it significantly. Of course, these two gentlemen, the younger days, the Coulter brothers, and eventually when they became older, we all know how they have changed lives for all of us. And of course, the first departure, the history of it, I've given so many times previously. I'll not get into details of this. But there was a very interesting story, which in fact stands published also about it. And they say when these brothers went to the US Patenting Authority for asking them to give them a patent for this technology, all they were told is you can't patent a hole. Well, as they say, the rest is history. They were eventually able to get their patent for this. And eventually they did talk about, get an instrument in place which we all are using now, and that technology stands today even after almost 75 years of its existence. The interesting part of this whole thing is that did we really start from the impedance analysis as far as the hematology analyzer was concerned? The answer is no. In fact, the first step was a fluorescence-based cell counting long, long ago, and of course, a lot of it was done in a lot of other cases. And we also know about the Coulter principle. I'm not getting into details of this, but this is one histogram part of it, which Dr. Sukesh always tells in his presentation. If there is one thing which he would always want to keep intact, and that would be this particular graph. And rightly so, because it gives you the cells in the most native state, and you're actually able to get the information from it, which is pretty varied. And from there, you are able to actually decipher a lot of information as well. And of course, I did tell you about the patent, which was for the flow cytometry part of it. This was the light scattering instrument, which was using the red blood cell volume and hemoglobin concentration. And of course, the Epstein was the one who gave us this whole thing, the Technicon instruments previously, flow cytometry based. All this was done long, long, long back ago. So if you look at how and why we're talking about analyzers today and how they have evolved over the years, the concept was primarily revolving not around hemoglobin or not really around platelets. It was primarily revolving around the white blood cells. Okay, and that's how the whole concept came up. You were talking about the routine 3-part differential and then the 5-part differential. And this whole concept came about from this small little thing which we're using in our laboratories, and we still have it in our laboratories today. And that was a hemocytometer. That's where the origin of the word comes, which Dr. Sukesh uses in his presentations very often. Now, if you look at this particular counting part of it, what were we trying to do when we were trying to count? We had certain reagents which we were using, We had the distilled water there, which was meant for lysis. We had the gentian violet, which was meant for staining. And of course, we wanted to keep the pH at a certain point, put it across into the chamber, and then using the grids there, we would count them. And of course, we knew that we had that factor which we would multiply and give the counts out. Right? So I want you to remember this part of it for sure. So you had lysis, you had staining, and you were adjusting your pH, right? This is what you were doing manually. And what happened when we went on to the hematology analyzers? We did the same. We just got our chemical reactions. We lysed the red cells. We stabilized the white cells. In some cases, we permeabilized them. We used a dye into it. Sometimes we never used a dye. And to expedite the whole process, what did we do? We kind of heated the whole thing, put it at a temperature which was higher. And then once we got all that, the cells were processed, got into the analyzer, and it gave us the information in the form of a visualization. Now, previously, we were looking at it under the microscope, and now we are looking at it from a hematology analyzer standpoint. So practically, if you look at this whole concept, you're still doing what you were doing manually. The only thing that you've changed is you're expediting it, and you're using reagents in certain concentrations to make sure that the cells are able to give you, that reaction, what you're expecting quickly. And eventually, all this you're getting into form of a digitized scatter plots and histograms. So it's as simple as that. You've only transformed what you were doing manually previously and putting onto a hematology analyzer. And that's how the entire automated differential counting came. So you had this 5-part and the 3-part and the stuff like that. And obviously, anything which was nucleated would interfere in your analysis. And now you started asking for more. You said, okay, I got my counts, great, but now I want to know that my NRBCs are counted correctly separately. I don't want to do an uncorrected and a corrected leukocyte differential, etc. And then again, we worked on certain reagents, modified the mechanics of, of the instrument in such a way that we were able to get all that information from the analyzer itself and getting the information regarding your white cells, your WBCs, your RBCs, and a lot of other parameters that we were talking about. So if you look at parameters which are available today, just look at the number of parameters which are available in all sorts of analyzers. And I've not specifically pointed out a specific analyzer here. There are all sorts of information which is coming. Look at just 32 parameters for the red cells, including the calculated ones. You have almost about 27 to 30 parameters which are coming for your white blood cells. And again, about 71 odd parameters, which is like counting all of them together. Now, when you look at all of these parameters together, the information is amazing. Add to this the research parametric data or the cell population data, which we have already seen in our laboratories and are working also on it. And some papers have also been published by Dr. Nair and others. So in such, look at the information which is coming out from a hematology analyzer. It's almost about 150 to 200 parameters that you potentially can work on, and it can actually help you define a disease and get into the nitty-gritties of it. So I'll change gears a little bit, and I'll tell you something interesting new, what is happening now on some of the analyzers, keeping in focus the Mindray's newest stuff which they have added onto it. I was invited for a talk some time ago, a few years ago, in fact, prior to COVID, where the talk was about using platelets, worrying about platelets at the time of monsoon. Monsoons, rains, mosquitoes, and the problem of platelets which starts coming up. And at that point of time, I had labeled my talk as the ooh, the ah, and the ouch of the platelet count, only to make it a bit catchy, nothing else. Little did I realize that now I'll be also talking about the I's, the O's, and the F's, and now the H of the platelet count. So, how platelets have also evolved, because platelets still happens to be one of the most dynamic and most controversial parameters, if I may call it so, because counting them still happens to be one of the biggest challenges which the industry is facing. So when we talk about platelets, the I, O, F, and H, they all stand for impedance, the optical, the so-called fluorescent, and then eventually now the hybrid platelet counts. And this hybrid platelet count is nothing but a count which has been taken out from the impedance channel and has also been added from the retic channel, and then the differential ones. And now once you've gotten the combination of it, you remove all the red cell debris, etc., out of it. And finally, you give a count which is called the platelet hybrid count. And it's been claimed that gives you information which is almost equivalent to what you would have otherwise done manually. And they have enough studies available on this. I have no direct work on this at the moment, but we are planning to work on this, and hopefully we should have some data next year with you. So practically speaking, We've added another armamentarium to the platelet counting from where we started, the I's, the O's, the F's, and now the H. All right. And now the theme of the conference. We're getting into what is called technological convergence. We had COVID. We were looking at so many parameters at that point of time. We wanted to look at CRP. We wanted to look at D-dimer. We wanted to look at so many other information, IL-6, etc. The question was, can I have one single sample which goes across into the system and I get all this information from that analyzer in one shot? And that's where perhaps the entire convergence came in onto the analyzers which were from Mindray. And this was primarily working on the CRP and the ESR in this analyzer. And they have, again, done enough studies on this. We are kind of in the process of actually looking at this in our center also. And looking at ESR, getting the ESR information done on a what they call more and less. And more importantly, converging the other technology, where you were looking at classical Vestigrans to a charge-based ESR identification and getting that information from the same tube which went into the hematology analyzer. And finally, looking at CRP by embedding what is called the lattice-passed particle-enhanced immunophenotypic method within the analyzer. So you have another channel in which you are identifying the CRP. So you now have a technological convergence, right from your classical impedance to fluorescence to hybrid, and then to add to it ESR and CRP and lattice agglutination, stuff like that. So therefore, real technological convergence, which is happening across the platforms. All this done, do we still have issues? Yes, we do. So we still have issues with hematology analyzers. We have numerical data, but PBF sometimes can be a challenge. Even with digital morphology platforms on board, and we do have one, we can still have challenges there. Graphical data, do we really utilize it to the maximum potential? The answer is still no. A lot of people don't even look at it at the moment, even today. And then finally, to emphasize that having automated data and compiling it along with the information which is coming from the rest of the parameters there. All this complex information which is coming, can we just collate it together and give a clinical decision basis this? Is something available on that? Yes, the answer is again, yes. We do have something called clinical decision support system, but again, very sparingly utilized in majority of the states across the country here in India. And again, it is also important to realize that you can have sometimes very complex and time-consuming preparations of certain samples if you do not have an integrated solutions to all of this. And of course, we still have a need to draw the sample. You can't do anything unless you have a sample with you. So can I do something, maybe on my watch, something comes up and says, oh, your hemoglobin at this moment of time is 14 grams. That would be something which would be wonderful. There's another very interesting thing which I want to put across to everyone. Reticulocyte counting on different analyzers is not the same. You don't get similar numbers. So don't chase the numbers, just chase your instrument. And every time you do the instrument, you are expected to have it like that. But why is it so? Is because if you see, there is a reference method against which you are actually standardizing your instrument. And this is never a straight line in between. So if you have tilted lines the way they are, whatever you will count here will be kind of matching at the lower counts. But the moment you go to the higher ones, they may not be the same numbers. So therefore, counting across counters, as far as the numerical data of reticulocyte is concerned, it may not give you exactly the similar information. So this is something which we all need to keep in mind. In addition to that, there are other unique issues with pediatric samples. I'll not get into detail to this, but again, having samples in that small microvac and then trying to put it into the analyzer itself, running it into a single shot can become a challenge. And lots of other smaller little issues wherein lysis of the red cells may not be adequate, especially in some of the hematology analyzers without naming them. So there are issues even today. While the paradigm is evolving, we still have things to do. And therefore, that gets us to the question, what's my wish list? Obviously, ye dil mange more. We want to have something more in life. And what else do we want? We want more accurate, more comprehensive instruments. We want to include more parameters in the blood counts. We want to look at the rare event analysis. I wish I could just run a sample of my stem cell analysis without, kind of pre-preparing it myself and just putting it in the analyzer, and it gives me the stem cell counts. Maybe detect some tumor cells, do some in vivo testing, which we do otherwise also on the analyzer. And of course, there are issues when we have clumping of the cells, and that time, can this give me something more? I don't have answers to all this at the moment. Yes, there are lots of things which are in the process, and I'll just give you what's on the anvil and what's probably already come in. There are some novel methods which are kind of in development at the moment. We have some quantum dot assays which are coming up. We have some small portable instruments which are also working at the same time. And of course, what I wish eventually, an in vivo blood counting technique which might come up at some point of day. We have newer contrast reagents like the quantum dots, which I was telling you about, and of course the rare earth metals. But the moment you talk about these two things, you are now escalating the cost to the next higher level. And of course, at the moment, it's still kind of a research tool. And more importantly, how do we use eventually all this data which is coming to us to make sure that it's giving us the information that we want? We're in an era where we've been through COVID just recently, and a lot of people are actually still wanting that I sit in my nice, cozy bedroom and somebody just walks up there and takes my sample, or actually not even takes my sample, gets me the information from my Fitbit and tells me, okay, you're doing well today, oh, you're not doing well today. So stuff like that. So that's what we are coming to the next. And of course, the need for portability of taking the instrument back to the patient somewhere in the remote areas. And now that is the biggest challenge that we face today. But has there been portability, which we are trying to talk about? The answer is again, yes. There are a lot of things which are happening on the portable part of it. And as Sir has also mentioned in his talk, the lab on the chip. In fact, there is a journal to that effect by name, The Lab on the Chip. And that they talk about how chips are being used today to ensure that we're able to give you exactly similar information on micro samples from a finger prick and get you the information which you want from a small drop of blood. Digital morphology and microscopy, we have already spoken about. In fact, Sir has also spoken about it, and I have also given you some information in my last presentation last year. And this has evolved significantly over a period of time, and it's becoming better and better with added machine learning technology, both on Mindray and on television platforms. These are some data which has come out from our MCAT, which we've used in Delhi. And you can see that it's been able to identify all of these abnormal cells and actually gives me very clear morphology and tells me that your sample is actually containing blasts. And of course, we all know the beautiful information which it gives you, like the ones which you would look at the textbook and feel great about it. All that information is now available at the back of your hand. And again, not only looking at red cells, even identifying them separately, and counting them also is also equally important. For example, these abnormal macrocytes, you're able to pick them very distinctly, enumerate them very clearly, and look at this beautiful, the digital morphology picture of a basophilic stippling. Now, this is something which the analyzer is doing it for you and actually identifying it for you. And then finally, you just have to look at it at your leisure and just report it out. So that's the next last thing, which perhaps is still kind of on the anvil, which is happening. There was also a resurgence of what I called the image-based cell counting, and unfortunately, it never saw the light of the day. And this was the so-called classical bloodhound instrument, which was there from the Roche Diagnostics M511, which eventually did not see the light of the day, where they were doing the printing part of it on a slide and then eventually taking image analysis. Unfortunately, it never happened. It did happen, but it did not happen eventually on a commercial level. And again, looking on a chip, as I already mentioned to you. Finally, and not last but not the least, we are now looking in an era, we're looking at in vivo analysis of your blood cells. So, it is just maybe a few more months or years where we will be actually looking at our watch and saying, okay, my hemoglobin at this moment of time is 12 grams and my platelets are 3 lakhs. Okay, I'm good today. And next day, when you see that my platelets have dropped, you say, oh, do I have dengue now? Shall I look for my dengue? That kind of a thing. I think, it's pretty exciting what you're looking at as far as the in vivo automated blood cell counting is concerned. A lot of things which are already happening. I'll not get into details of this. I have no direct experience of this, but I have read through this and I've realized that, yes, things are changing and the speed is actually pretty interesting as to what is happening. So we have a lot of technology which is on the anvil. We have optical absorption, we have elastic scattering, we have inelastic scattering. Don't ask me what all this means because I really, really don't know all of this. But what I know is that things are changing and they're changing at a rapid pace. The only thing is, how much of a pace do we keep with it? And how much are we willing to adopt in our routine practice? Whether we like it or not, the technology is going to come in. And we are definitely needing to make sure that we adapt to it as quickly as we can. So therefore, I leave it with you with this slide, not really confused. I don't think you guys are confused, but I'm still confused as to where we stand at the moment. But I still expect that my wish list, what I had, the analyzer science is actually going to evolve and grow and grow and grow and further. And of course, we want to see the beautiful small little marrows, the special techniques, etc. Of course, the money part of it, which my colleague Tina is going to teach you tomorrow in a big way as to how to earn money from money. And then finally, it's also important when you try to adopt this technology, into your systems, what you're driving and your restraining forces. It's not just about just getting something on board. It's also about the fact that what are you trying to do? What's your life size? What's your scope? Are you public or private? Do you have operations which are 24/7 or not? Are you looking at a reagent rental? Are you buying it out? What supply methodologies do you have? What is your middleware? Are you ready for integration of technology in your systems? And finally, what are your personal preferences and biases? Because all of us have, at the end of the day, I may like a specific set of instrument and I may not be liking the other one. But when you look at all of this, above all, what still matters is how much money do you have in your pocket? Are you willing to spend? And to earn that money and how you make that money, we have a lecture tomorrow. I think with that, I'll end my talk today. Thank you very much. Should there be any questions, I'll be happy to answer. And I would like to thank my team back home, as well as so many mentors which I've had all the way. Dr. Sood, Dr. Bhargav, Dr. Sukesh, Shirish. Of course, all of them have contributed in some way or the other, and all my technical staff who have actually helped me grow all these years. Thank you very much for your kind attention. I'll be happy to take questions if there are any.
Any questions, comments?
Yes, sir.
It is an eye-opener, Anil, and a great lecture.
Thank you, sir.
But I feel that technology on one side and microscopy on the other, we are creating a wedge between the two. I would be very happy if we can create a bridge between the two and get the best out of both the technologies.
So to just add very humbly in this, I think the effort right from the days Dr. Nair started this whole activity of looking at data science from the analyzers to the place where we took it over into Cube, and then eventually when we are sitting across to you today, the emphasis the thought has never been that they are at war with each other. No, the answer lies somewhere in between. We want to bridge the two to ensure that whatever best can be taken out of both the instruments and the morphology and the mind of the individual, so that the best thing comes across to the patient. And that's what we are actually eventually wanting.
So, I actually ignited this thing. I went to Medanta Medicity when he was laboratory hematologist there and gave him one non-conformance. What's your slide review rule? That transformed him.
That's absolutely correct, sir.
I have a question for you. I feel that the hematologist or pathologists in hematology, we are losing the battle with immunochemistry and chemistry. They produce every year new parameters, and we don't have new parameters, reportable, reimbursed. What we are doing wrong, because in the studies we do every day or every week, but we see that some parameters are better than procalcitonin, are better than, and why we are not able to bring all this knowledge to a final approval in the guidelines or in the clinical use? That is my question to you.
I think if I look at it from India's specific answer, the current challenge that what I feel is that we don't integrate our data. Somehow, I have some data. Sir has phenomenally great data available with him. And a lot of us don't integrate our data and then come out with something which is substantial for us to go across and get an approval. Because now what has started happening, even in India, we have this Medical Devices Act, which is expecting us to run the instruments, the samples not on a research mode, actually run it on a IVD kind of a mode. So practically speaking, in my opinion, I think if we collaborate together, this effort is also on that direction. If we collaborate together, get hold of some information which is useful and it's giving us information that's unquestionable, I'm sure that we will be able to add these parameters which currently are still so-called RPDs. So it's not that we don't have the data, but we're not kind of collating it and taking it further. Anything else you would like to add?
No, I think Anil has very clearly put it. Immunoassays, they have to find new parameters. We have a cell and we know what is happening in the cell. Only thing is we are not maximizing on what happens in the cell. I think, multiple centers, for example, the first paper that came from Fernando Chavez, that was eye-opener. In fact, Ramon was the inspiring part of that paper. They found that there was a finding and a significant finding, but they could not explain the entire finding. Though they started the study with a particular idea, but that idea did not work, but there was a finding. So I think, we are not maximizing on what we have. Let them discover whatever parameters they have. But I think, Paul Ehrlich has not done a simple job. He actually ignited a flame. It's for us to maximize on those things and see how the cell counter can uh, reproduce that and make it better. Because we are still not, we have not maximized anything from the cell. We are looking at new parameters in immunochemistry, but the cell which is changing, we have still not, like we both are arguing. HFC is lymphocyte. I say it's monocyte. Like, Tina did a work on HFC. She spent a good amount of money and life on chasing lymphocytes in HFC. She didn't get anywhere. So thing is, because obviously those cells are there and they are changing reacting to certain situations, which are, everyday situations. But we are not doing anything about it. We don't need to add anything extra. Just recognizing those changes that happen makes a lot of difference. And I think this platform is creating that scenario. And I think, Raymond, you don't realize that you actually ignited the whole thing.
That's a fact.
Yes. You don't realize that you ignited the whole thing. And now India is the place where everybody looks at these changes. No other place in the world.
You made a good point, and maybe we have to have, after this meeting, using that we are in the same city, next year, 1 or 2 days in that we can sit and discuss and say, okay, what we have this year. Okay, this year you have published something, Anil had published whatever. What is good from that? What has clinical value, as you said, and to go together and to discuss whatever we have to discuss internally, but to arrive to a conclusions, put the egos apart and to get agreements and to go for guidelines. And I think next year I propose to extend maybe 1 day more for discussions, what we can apply and make a consensus, and everybody will apply this parameter in the clinical practice.
So that 1 day extra will be for people who can come and possibly do some studies which can become a publication.
Absolutely.
So, sir, just to answer one question and to add to what Anil said, I have not seen a peripheral smear for a diagnosis in the last 7 years, but I have made fantastic diagnosis in the last 7 years. I have not seen a single peripheral smear. I've entirely dependent on data from cell count. Cell counter gives a lot of information. And only thing is, I have maximized on that information. I know that. I know my cell very well. I know my stain very well, because most importantly than the cell, you should know your stain very well. So I know my stain very well. In fact, I developed the stain myself. Modified right genes. I call it modified right genes are stain. And even the cell vision people say that I have never seen such a fantastic smear in my life.
Had you seen the peripheral smears also along with the data? Publications by your juniors would have been 10 times.
So thing is, sir, you must realize one thing. I'm a teaching institute and a big teaching institute. So I make smears not because I have to see the smears, but I have to make the smears because my students have to see the smears. So when the student, one of the best smears, like for example, DM hematology student comes and sees a smear. The first smear he sees is CML. CML is one of the best smears anybody in their life can see. It's probably the most beautiful smear in a student's life. And he gets excited. He comes, sir, look at the smear. I said, let's go to the cell counter first. Then I don't even look at the scatter plot. I only look at the histogram. I said, CML in chronic phase. He said, Diagnosis. I said, that's diagnosis. Do you want to look at this mirror? I said, will I make any change in the diagnosis? No, sir. So he actually asked me, is life so simple? I said, life is simple as long as you look at it as simple.
Any more questions, please? So thank you, sir. And thank you, Dr. Handu, for your
Very much.
wonderful talk. May I call Dr. Sukesh Nair to felicitate Dr. Handu, please? And may I call Dr. Ramon to felicitate Dr. Sukesh Nair, please? The trio. The trio photo. Thank you. Thank you very much. So may I call Dr. Ramon on stage for his next lecture? And may I request Dr. Ajay Shah to chair the session, please? Sir, आप यहाँ बैठ के भी कर सकते हैं।
This is a very long and elaborate introduction for Dr. Raymond. I will need that slide. Dr. Raymond Lopez is a medical director specialized in hematology. And all the time I have seen him in the cube since last many years. His past experiences are medical director at Immunocura Medical. Is a medical director in Sysmex Corporation, medical global scientific director for Beckman Coulter. He's a member of American Society of Hematology and has worked as a representative of ICSH in the WHO, January 2010, Executive Board meeting. Dr. Raymond is an expert in clinical and laboratory hematology, oncology, immunology, immunotherapy, coagulation, almost everything in hematology. And I think we will learn a lot today from him. I will give the mic to Dr. Raymond. Thank you.
Thank you so much. Today we are going to talk about not clinical use of parameters, even if I will mention something about that. We are going to talk about what to do, what we have to do clinically with the patients. And this comes from laboratory for sure, because when I was beginning to analyze the first slide, can I move that? Is the last version? Yeah, today we are looking for the databases and helping customers to publish the results and to collaborate with them. We were realizing, I was realizing that something was wrong in the history of the hemodialysis patient managed with laboratory parameters. In that time, Carlo Brugnara, one famous hematologist from the Brigham and Women Hospital in Boston, and Dr. Auerbach, famous also in America, they were promoting the use of hypochromia measured by hypochromic red cells, CHR, for the detection of functional iron deficiency and the consecutive treatment with iron. And that was said and said and said, but the facts were not showing that. The facts were showing that the patients with hypochromia were the best responders. If they say that is wrong, why they respond better to the erythropoietin? And looking at that, I was beginning to investigate why. And I was beginning to classify the patients in another way in the databases to see what's going. And the fact is, at the end will come this presentation that is fruit of many years of not laboratory only, I think mainly clinical development or what to do with patients, a part of laboratory diagnosis. Iron or not iron? That is the question. This is the protocol. It was when I was beginning to face this problem, that mainly the management of the iron, intravenous iron for hemodialysis patient was based on the transferrin saturation results. These were the milligrams of intravenous iron per month that you were administering to the patients based on what? Oops. The laser is that. Okay. Based in the ferritin levels, less than 100 micrograms, between 100 and 500, 500 and 800, and more than 800. As you can see, that the only moment that they stop the iron is when the ferritin was more than 800. Again, the transferrin saturation lower than 20 was really indicating high dosage, but here it changed because when transferrin was more than 20 and ferritin was between 500 and 800 micrograms, they were not giving iron. The fact is, applying that literally, when you have a database of patients with hemodialysis, treated with hemodialysis, the majority of them have ferritins of 600, 700, 1,000, 1,300, etc. But the problem becomes worse because after Carlo Brugnara and Auerbach and all of them begins to say that no, you need to replace transferrin saturation, you need to replace with hypochromic red cells and forget ferritin. Ferritin, they said, is an inflammatory protein. And increase with inflammation, don't care. And transferrin saturation have a lot of mistakes. They were criticizing. In my facts was not true. When I was doing a correlation coefficient between transferrin saturation and the hypochromia measured with CHR, correlates perfectly. Correlates perfectly with all the possible errors of transferrin saturation. And that was really wrong for me. Basis of the new approach for iron treatment. The bases are this article. Many of you will know this article. It's one of the Bible articles because it's published not only in the New England Journal of Medicine, it's one of the first times that somebody that I know personally, Dr. Gunther Weiss, Professor Gunther Weiss from Innsbruck, Austria, defined very well the anemia of coronary disease without any influence of any pharmaceutical or any economical interest, really free of any link with any economical interest. What is new in this graph? He gave me the permission to use it, in that he mentioned what's happening with the iron in patients with inflammation, in patients with anemia of coronary disease. We know also now they prefer to call anemia of chronic inflammation, no anemia of chronic disease. Anyway, the thing is, he defined that when you have bacteria, but also happen with cancer or with autoimmune disorders, there is a process that the CD3 cells produce an increase of interferon, and the interferon produce also, because the monocytes in the interleukin-6 epsidin, the epsidin close the door of the liberation of iron from the macrophage. It's called ferroportin. And that makes that when you have certain situations, the body and the evolution of the humans that is very 100,000 years, the body knows that in certain situations like cancer, like infection, like inflammation, iron is very toxic. What the body is doing is putting all the available iron, all the iron that is serum iron to the ferritin and to eliminate all the iron. And this is the process to avoid we have the toxicity of iron in this situation, because the iron is food for the tumor. Iron is superoxidant in cases of autoimmune disorders, and iron in infectious disease is also feeding the bacteria. Bacteria loves iron. So this is the reason the body is very intelligent with this process. This process is to avoid the toxicity of iron, and the iron is put in a safe place here in form of ferritin. But ferritin contains iron, even if it increases in inflammation. This is the table they did to diagnose anemia of coronary disease. And I want you to pay attention in something that you know, all of you, you are experts in laboratory, but I want to pay attention on that. Iron is low in anemia of coronary disease, in iron deficiency, and in both conditions. For this reason, when you are going to talk about diagnostic of iron metabolism, forget iron. Yes, forget it. You can do it, but not enough to take any decision. You do it to assess iron deficiency, but don't take any decision based in serum iron. When I say you cannot diagnose an iron deficiency without an inflammation marker, they say, what are you saying? Yes, I say that. Because iron is not enough. Can be an anemia of coronary disease, can be an infection, can be an autoimmune disorder, and now it's full of autoimmune disorders. After COVID, there are 300% more autoimmune disorders than before. But they said you cannot take decisions based on iron. It's not enough. Okay, transferrin. Transferrin is quite useful because in anemia of coronary disease, it's reduced to normal. We are beginning to have something with clinical use. If ferritin is not high, don't take decisions to give iron because have to be increased to administrate iron. When it's normal or low, don't give iron. Transferrin saturation, useless for taking decisions. Is reduced in all of them. Don't take decisions based in transferrin saturation, not in serum iron. Yes, assess that the body has a functional iron deficiency. Functional, that the iron is not arriving to the red cells, to the NRBCs to produce hemoglobin. But we don't know the cause. The cause can be because the absolute iron is low and the deposits are empty, or the deposits are full, but the body is protecting this iron to be available because it's bad. Okay, good. Soluble transferrin receptor is useless because it's normal in anemia of coronary disease. What they did, the magic people selling soluble transferrin receptor, a trick, a statistical trick, very nice statistical trick. They divided by logarithm of ferritin. You can divide the glucose in non-diabetics by logarithm of ferritin, and the parameter will be useful for the diagnosis of anemia of coronary disease. Just divide any parameter that is normal, the total proteins, by logarithm of ferritin, and you will have a good parameter for anemia of coronary disease. But when I see that, I say, oh my God, how nobody said that before? Because it's a statistical trick. For the reason, forget soluble transferrin receptor and don't use the ratio. But what's going? What is the base of soluble transferrin receptor? What is important is in anemia of coronary disease, there are more receptors in the NRBCs because there is a functional iron deficiency. But anemia of coronary disease have an increase of tumor necrosis factor in the bone marrow, and the total number of erythroblasts is reduced. This is the reason there are more receptors that you can detect with flow cytometry, with CD70, but the total number of soluble receptor is normal. If you want to see the transferrin receptor, you have to measure it in the cells with flow cytometry, not the soluble one. And divided by logarithm of ferritin, I tell you, it's like you can divide anything that is the same for all the patients with the logarithm of ferritin. That will work. Cytokine levels. You can put here sedimentation rate, C-reactive protein, ideally IL-6. From all the inflammatory markers, the more specific for iron metabolism is the IL-6. But if you don't have, CRP is also a good marker. And if you don't have CRP, sedimentation rate. If sedimentation rate is high, and you only have the serum iron that is low, don't give iron. Order a transferrin, a C-reactive protein, or order a more specific test for inflammation because sedimentation rate is not specific. But don't give iron till you have or a ferritin, because ferritin is different between them. Look, ferritin is normal and is reduced in iron deficiency. That is useful. Ferritin is useful. Inflammation marker is useful. And this is the translation of the table of the same article of Gunther Weiss, in that we can see that when you have an anemia suspicious of iron metabolism anemia, you cannot do nothing without a biochemical or clinical evidence of inflammation. And here you can put CRP, ESR, IL-6, whatever you want. But don't take any decision about iron metabolism. The first step is to assess inflammation. And that is the trick, don't make mistakes. Second, transferrin saturation. That shows you that the iron is not available for erythropoiesis. You can replace transferrin saturation by red hemoglobin, RHE, CHR, hypochromic red cells is correlating very well. You can put here in this level or a biochemistry marker or hematological or both. But this is after ferritin. Less than 30, I would say less than 25. But less than 25, 22, some cutoffs in some laboratories, they say normal, more than 15, oops, more than 12, oops. For me, they are including as normal latent iron deficiency. Ladies that have low ferritin but still don't have anemia because the bleeding was very recent and they will develop anemia after several months. But the majority of the levels I see in many laboratories of ferritin are wrong, because they include latent iron deficiencies and the levels are less than 22, the normal values, and the high levels are too high, have to be 100, 125. But the majority of the laboratories say ferritin is normal up to 300. Wrong, again, because they include hereditary hemochromatosis in the group of normals. And there is many of them, and they make the level of 300 when 300 is not normal. But that will be fruit of another discussion. The thing is, after that, or forget that, the soluble transferrin receptor in that time was fashioned, but forget that because it's not useful parameter. Soluble transferrin receptor. And at the end, you have the diagnosis of iron deficiency, of anemia of chronic disease, or sorry, of anemia of chronic disease or mixed anemia. What is this mixed anemia? It's complicated. You have inflammation, cancer, infection, or autoimmune. You have low ferritin, not very low, 22, 23, 25, not very low, but low. And you have low saturation and low iron. What happens? My first patient as hematologist in a hospital, when I was not learning, I was taking decisions, was a patient, 73 years old, 74 years old. Oh, typical iron deficiency. Wow, it's an iron deficiency. What is the treatment? The first question I have to do myself is, what is the cause for his iron deficiency in this 74 years old man? It was a colon cancer. And what's the typical CBC of an iron deficiency? Microcytosis, hypochromia, low hemoglobin, but was not, iron deficiency was not a diagnosis, was a symptom. What happens if I give iron to a colon cancer? I will increase ferritin and ferritin, but the hemoglobin will remain the same. Why? Because the body is intelligent. All the iron I will give will go to ferritin. And that is what you see. All the iron goes to ferritin because the body says, no, please, don't give me iron because I am feeding the tumor. Okay? And that is the situation. How we can detect the mixed anemia is the more difficult one because there is an inflammation marker, or there is a cancer, or there is something that can block the iron. You can try for 1 week or 2 weeks, iron will not kill the patient, but don't give intravenous iron, give oral iron, because if the hepcidin is high, you will not absorb the iron, and you will be in a safe place. Okay, good. This is the red cell maturation. Everybody knows that. I am not going to insist on that. But this process, this process needs iron, for sure. And what's happening now, we will understand much better this graph from Gunther Weiss. the macrophage, if it's necessary, it's providing iron, to the cells. And you will have here the NRBCs with a pulse stain full of iron. Okay, you will see iron in the macrophage, but also in the NRBCs, siderocytes. What happened in anemia of coronary disease, but also in hemodialysis patient? Because they have inflammation, the process of the blood going outside of the body provokes inflammation. And they have all of them practically high CRP. Not very high, except if they have another thing in addition, like an autoimmune disorder that maybe was the cause of the glomerulonephritis, and finally the renal failure. But the thing is, this is the process. You have a normal serum iron, ferroportin is close, and the, let me see, normal serum iron here. Here. You have the ferroportin close because the epsilon closed the door, and the iron is accumulated in the macrophage, okay? Here you have the normal serum iron and normal circulation of iron. And here you have, again, thanks to a treatment, for example, erythropoietin, that the iron comes back again to the NRBC. Let's see more graphically, because this previous slide is not so clear. What happened when the epsilon, you see, when the IL-6, the first interferon gamma, after IL-6, after epsilon, and after ferroportin, that the ferroportin is closed. What happened? You are not liberating iron, you are accumulating iron. Ferritin goes up, and you can measure with a pulse stain that there is an increase of iron in the macrophages, but you will not find iron in the NRBCs. And the transferrin saturation will be low, and the serum iron will be low. What is important in the article of Gunther Weiss? It is very important to avoid the excess of iron deposits because the iron toxicity. And he mentions in his article a lot of articles showing that the iron is toxic in a hemodialysis patient. But let me choose one of them, the article from Geoffrey Tihan. And I just copy and paste. This is the reason Professor Gunther Weiss said, a study investigating measures to predict the risk of bacteremia among patients undergoing hemodialysis who are receiving iron parenterally showed that patients with a transferrin saturation above 20 and levels that ferritin higher than 100 micrograms had a significantly higher risk of bacteremia. And that is a fact. The patient with ferritin more than 100 have an increase of infections. For the reason, please, if you can have a patient with a lower ferritin, have it. Better 150 than not 800, as they recommend there. For this reason, be careful with that. This is the actual proceedings that many nephrologists are using. Be careful, because up of that, you have increase of infections, increase of endocrine disorders, diabetes, you have the problems of hemochromatosis. What are the revised best practice for chronic renal failure in nephrology and dialysis transplantation? Hypo percentage is recommended in this guideline to decide to give iron or not, ignoring ferritin, because they finally find that many labs stopped doing ferritin, stopped doing transferrin saturation. They were only giving iron according hypochromia, measured with the Siemens, with the Mindray, or with any Sysmex or EVA, or any instrument that can measure hypochromia. But patients with high hypo respond better, is what I found. And they say in these guidelines that the best predictor for response is hypochromia. They recommend to give iron, but the best responders were the patients that have hypochromia. Limitations of first percentage of EPO that were used in this time. In that time was only Siemens having a percentage hypo, that they have a poor stability, around 2 hours. After 2 hours, you cannot use any more hypochromic red cells. That is a limitation because many labs have outpatients, and many of the hemodialysis centers are not doing the analysis themselves. They send to another laboratory. all the transportation makes that this parameter is difficult to use because lose the stability and can be decreased or increased depending on the transportation. Needs high technology, expensive instruments that only huge hemodialysis centers can afford, or you have to send the samples to another place. And these are the hypochromic red cells. How to detect the hypochromia today? Okay, in Mindray, we have developed the hypo and its stability around 24 hours. And the laboratories can transport the samples from the hemodialysis center and not only high technology instruments. Okay, this is true. But are we going to decide to give iron according to that? Not clear. We will see at the end. We have to use other criteria for the administration of iron. And this is the technology Mindray is using, as you know very well. I will not enter on that, but you know that here we are measuring not only the forward scatter and the fluorescence, we are measuring the forward scatter and the hemoglobin concentration, the IPF, etc. And we can measure the optical platelets, and here we can measure in this diagram the hypochromic microcytic red cells and counted and reported for the use of the laboratories. But the thing is, have we continued using that and we can replace this transferrin saturation with hypo percentage? What do you think? Can we do that or not? Not. Maybe we have to take a decision based in the EPO percentage, but not, of course, this panel with the ferritins and these levels of ferritin. The clinical classification according to this table will be that iron deficiency, functional iron deficiency, normal, and excess of iron. Only when the levels of ferritin is more than 500 or 800. The rest, they don't care. Evidences for new approach of an iron treatment. This was the article that when I visit Dr. Gunther Weiss in Innsbruck, he showed me and permits me to understand finally where it was the problem and how to find the solution. Because the solution has to be based in clinical basis, not only in laboratory concepts. The thing is, he was doing this study just to see how the intravenous iron was changing the immune system. He measured interleukin 10, tumor necrosis factor, interleukin 4, interleukin 6, interleukin 12, POX. He was measuring many immunological parameters to see how the intravenous iron was affecting the immune system in patients with hemodialysis. He's surprised, and he told me that. What's that? Look, there were two groups of patients, therapy 0 and therapy 1. The ones patient receiving iron, 1, the patients not receiving iron. During 3 months, he collected patients of hemodialysis with the average of ferritin of 300, and he was following them for 3 months more to see what is the effect of intravenous iron. One received in erythropoietin and intravenous iron, the other with the same initial ferritin received only erythropoietin. And in the group of erythropoietin with iron, he was trying to see the difference between interleukin 10, 2.8, 2.6, 3.7, 3.8, similar, and here double interleukin 10 in the group that not receive iron, that in the group receiving iron. He was trying to see these differences. And he was looking for the differences statistically different between the groups of iron therapy. What was his surprise? After this study, look the hemoglobin. The hemoglobin in both groups, receiving iron and not receiving iron, 12.4, 12.3, 12.3, 12.1, 12.2, 12.1, 12.12, 12.1, 12.5 was the same. The group not receiving iron had the same hemoglobin. In this case, why the hell we need to give too much iron? You understand? This was the key that we were discussing together in Innsbruck. He got my idea and he said, I have an article that I never understood, because we were believing in back in Brugnara, in all these popes of the iron metabolism, and where they were wrong. And I said to Brugnara in the ASH meeting, when we present the data of the study, you are going to say, he shut up. He didn't answer to me. Okay? because he knows, and I was telling him, you were wrong, Carlo, okay? But this is the fact. And the fact is, we can open the iron thanks to erythropoietin and one protein that was discovered before this meeting in Innsbruck, erythroferron. Erythropoietin by itself, using erythroferron, is able to liberate the iron it needs for erythropoiesis. And that is the trick. You have the treatment with the same erythropoietin. And you don't have to intoxicate the patient with iron, and you don't have to increase the serum iron. The erythropoietin gets the iron it needs for erythropoiesis without increasing the serum iron, not the transferrin saturation. And that is the thing. The thing is, we can solve the problem, yes, administrating erythropoietin, as this paper made for other purposes demonstrated. And that is the percentage of patients. This is another fact that he said in his article in the New England Journal of Medicine. The percentage of patients with anemia of chronic disease who respond to therapy with erythropoietic agents is 25% for myelodysplastic syndromes, 80% in multiple myeloma, and 90% in rheumatoid arthritis and chronic disease. 95% only with erythropoietin respond. There is a problem in the solid tumors. One Swiss guy that was attacked by all the companies said that erythropoietin in cancer, in solid tumors, can increase sometimes the tumor growth, because some tumors have receptors to erythropoietin. You cannot use for tumors. If you don't demonstrate that erythropoietin is not promoting the growth of the tumor, because some tumors respond to erythropoietin. It's the only limitation. But the autoimmune disorders, the anemia of chronic disease, you can give it only erythropoietin, no iron. And you will help to improve the hemoglobin. Proof of concept with patients for the new approach for iron treatment. And the history, some of them, you know that, it comes from a very funny thing. Dr. Radmilevich, Professor Radmilevich, one of them signing, it was considered a pope also for iron metabolism. He was managing the treatment of cancer. And he gave a conference in the ASH meeting, in the educational program. And after his talk, I was going to him, a part of the question, the time for questions, and I was attacking him and saying, Dr. Radmilevich, I have this hypothesis, blah, blah, blah. What do you say? This is wrong. This is not true. And he refused my theory. And he told me, okay, $100 if I am right. And I provoked him to do the study in his hospital. And the fruit of this study he did, you will see now. We were collecting 21 patients from his hospital. In this hospital, they were not doing ferritin anymore. They were not doing transferrin saturation anymore. They were only using the hypochromia to give iron. The results of that, you can see the ferritins of the patients, 6,800, 5,500. The lower of them, 1,220 of ferritin. Okay? The question is this ferritin inflammatory, like Carlo Brugnara said, with no proofs? In the bibliography, he never mentioned a Pels stain in the bone marrow of this hemodialysis patient, or any proof that the ferritin is inflammatory and don't provoke hemochromatosis. No. But look, the ferritins, when they were checking the ferritin, they were saying, oh my God. Oh my God, the iron was going out from the ears. These are what we decided to do the gold standard technique for iron overload, T2 star. Magnetic resonance T2 star is the gold standard to check iron overload in hemochromatosis patients. For any reason, myelodysplastic syndromes with multiple transfusions is the gold standard. And we were measuring, and it was accumulated in pancreas. It was accumulated the iron in the liver and in the spleen, not in the heart, fortunately, not significantly different, but was an increase of iron in the spleen, in the liver, and in the pancreas. And we can see, I am not an expert on that, but for the experts that some of you will be, you can see a clear increase of iron in the organs, okay? That will be in red. And the more important, what we did after that, according to the article from Gunther Weiss, for the effects in the immune system of the iron, we were stopping the iron for all these patients. What was happening? You can see in this graph, sorry. In this graph, this is in a continuous line, the ferritin and the transferrin saturation. The ferritin and transferrin saturation from an average of 2,700 was going down in the time of the study that was 17 months, from an average of 2,700 to an average of 1,300. And they were continuous without treatment after that. For this reason, it was very, very interesting, this response. The more important for you, in a group of 21 LTH patients, this is the conclusion of the article, with high levels of serum ferritin, we demonstrated that increase in other parameters of iron overload in the serum, transferrin saturation and epsilon, and evidence obtained by T2 for iron deposition in the liver, spleen, and in some patients in pancreas. For this reason, we demonstrated that, and the more important, this continuation of intravenous iron for 7 to 17 months, while still receiving erythropoietin, resulted in a significant decrease in serum ferritin and transferrin saturation without changes in the hemoglobin levels. The hemoglobin levels were the same for 17 months without iron. In America, you are not reimbursed administrating erythropoietin if you don't administrate iron with erythropoietin. These are the guidelines in America, not in Europe or in India, fortunately. But these are the facts, okay? In case where soluble ferritin levels are still increased, repeated T2 can alert the physicians of iron deposition, and they continue not giving iron after this. My proposal, this is less ambitious, that we have to only give iron if the ferritin is between 150 and 400. But the more aggressive, that I will do it if I am the responsible, will be that. Only give iron if the ferritin is between 150 and 250. If it's more than 250, stop iron. This is my proposal of treatment for every hospital in the world. Okay? Ideal iron status. Good. But what is the role then for hypochromic red cells or hypochromic reticulocytes in the management of iron treatment? Hypo and RHE. Very clear. We have demonstrated that the patients that have high hypochromic and low RHE are better responders. For the reason, if it's something true, these patients will respond to erythropoietin. When these parameters will be normal, you have to investigate other causes for anemia. Because a patient in hemodialysis, as everybody, can have B12 deficiency, can have folate deficiency. By the way, they are administrating folate to them periodically, but we need to investigate. The patient that will respond will be the patient with hypochromia measured in any way. That is the conclusion, not to indicate the treatment with iron, but to confirm that the erythropoietin will work. If these parameters, the patient don't have hypochromia, pay attention, make a haptoglobin, B12 deficiency, B12, folate, do a screening of anemia to maybe the patient have another cause for anemia that we need to investigate. Summary, intravenous iron can be toxic with ferritins higher than 100 micrograms. Clear. Patients with a ferritin lower than 100 don't respond to erythropoietin. This is a fact. I checked it too in the studies I did. For this reason, we cannot keep the hemoglobin lower than 100. This is the reason the level is 150. Okay, good. We need to keep the levels of ferritin as close as possible to 100, and we'll have a good hemoglobin with the lower toxicity due to excess of iron. Serum ferritin increase with inflammation, but it contains iron. We have to check iron overload in patients with very high ferritin to investigate hemochromatosis symptoms, diabetes, liver cirrhosis, etc. We have to care about the patient, other organs, and not only the organ of problem we are involved. And that is a lesson that we have to have. we don't have to care about only our problem of erythropoietin and hemoglobin. We need to care about other things. One other example is statins for cholesterol. They reduce the cholesterol, but the myelin covering the nerves is 100% cholesterol. People receiving statins have been now beginning to be demonstrated that they have problems with the central nervous system, more degeneration of the nerves. We have to care about the rest of the things. Thank you for your attention. Is any question? I'm sorry, you have to ask.
Are there any questions, please?
No, this is not a question, but a comment. See, here what we do is that whenever there is suspicion of iron deficiency anemia, and the patient has chronic renal failure, so as we give erythropoietin, we also give iron, because whatever iron is present in cases of chronic renal failure, that is not available for erythropoiesis. So that is the reason we have been giving erythropoietin along with iron, so that as the process of red cell manufacture starts, iron is available so that it can go into the early, intermediate, and late normoblasts, and then they can mature into red cells. That was the basis on which we have been giving, and we are still giving. Most of the clinicians are still giving in our cases.
Yeah, I can answer without microphone. And this is what it was said. This is what was said and what everybody is doing still. Some hospitals in France, not many, because of course this is not promoted by any pharmaceutical. There is no any product behind. Of course, this is not promoted. It's only some hospitals in France, some hospitals in Italy, and more people are aware about that. But the thing is, it's true. Erythropoietin with iron liberates the iron and solves the problem of the functional iron deficiency, but not because the iron, it's because the erythropoietin. But because what happened in the patients with no any control, the ferritin is increasing. The erythropoietin liberates the iron it needs. It happens if you give iron or not. If you give iron in addition or erythropoietin, that erythropoietin is the one solving the problem, but only thing you do is to increase ferritin and increase the ferritin. If you don't control the ferritin, they will increase because all the iron you give will go to the ferritin. And yes, the erythropoietin plus iron solve the problem, but not because the iron, because the erythropoietin. And that is what we discover with these studies. That is the erythroferon, the protein that the erythropoietin is activating, that opens the door and liberates, doesn't matter, because we demonstrated in this study and in the study from Gunther Weiss that the erythropoietin alone, if you have more than 100 micrograms of ferritin, you are going to have the same hemoglobin. And if it's demonstrated that ferritin more than 100 is toxic, why to have ferritins of 300, 400, 500, 800? Why? I recommend, please, if you don't believe that, do T2 star. Do few patients. It's expensive treatment, but before to change the proceedings in your hospital, don't trust me. Check it. Check it with a T2 star if they have iron overload. Some of these patients with inflammatory ferritin that is not toxic. Check it. Check my findings with Professor Razmilevich. But the erythropoietin is the one solving the problem in this equation, not the iron.
Ramon, just one query that I have. You know, we were talking about hypochromic red cells, and we were also talking about the red HE out here.
Okay,
Yeah.
Sorry.
So my question is, the reticulocyte hemoglobin equivalent, RHE, whatever it's called, can we not make that pivotal in deciding whether we are going to give, and EPO levels in combination, and then deciding what are we going to give in such patients? Would that make a better combination?
I think hypochromic red cells is very important because has demonstrated and is mentioned in the European guidelines that is a good prediction factor of response. And it's published that. But there is have hypochromia will give me the insurance that only giving erythropoietin, I will solve the problem. That is the reason we need to measure it. But for the opposite thing that they said, not for administration of iron, for the insurance that will respond. If hypochromic red cells are normal, be careful, because maybe with only erythropoietin will not respond. We never happen in these 21 patients, and in the other patients that Dr. Weiss did, it never happens, but can happen. They can have anemia by other reasons. They can have hemolytic anemias, they can have autoimmune hemolytic anemia, they can have other causes of anemia. If the hypochromia is not present, the only thing you need to do is to investigate. And we need to do hypochromic red cells, but not for the purpose that was promoted by Brugnara, Auerbach, etc., etc., etc. That is the conclusion. We'll assess that you have to give, the patient will respond.
So, Ramon, the work of erythropoietin, which has come from the renal tubular cells,
Yes.
is to increase the erythroid hyperplasia and the
Yes.
red cell production.
Yes.
While the red cells may be produced, whether it is having hemoglobin, doesn't have hemoglobin, doesn't matter. But the issue is that erythropoietin will increase the red cell production.
Yeah.
Now, obviously, erythropoietin does not have the impact on the hemoglobin content of the red cell.
It has.
Maybe, but does it increase the transferrin receptor? Does it increase the what do you call the iron metabolism? Does it? I mean, other than increasing the red cell production, does it also have an impact on hemoglobin content inside the erythroid? When, see, for example, in a patient with thalassemia or a patient with iron deficiency anemia, there is increase in erythropoietin. The red cells are being produced, but there is hardly any iron to produce the hemoglobin. So, thing is it really to focus on erythropoietin alone rather than the hemoglobin production also?
The thing is, the key of erythropoietin is, sorry.
Mr. Red Cell.
The thing is, in the body is very intelligent. Serum iron is toxic in a hemodialysis patient and in any inflammation patient with inflammation. Serum iron is toxic in any patient with cancer, and iron is toxic in every patient with autoimmune and bacterial infection. We expect that the body is intelligent, and we keep the transferrin saturation, that is the measurement and the hypochromic, that is a marker of available iron, we expect to be low, because we know that in these situations, the iron, available iron, is toxic. The fact is, the important is, the cells just have the NRBCs, the enough iron to produce the hemoglobin. And I don't care if I found hypochromia. The important is that you keep the hemoglobin, and you decrease the important is to keep the patient is not anemic. Hypochromia and functional iron deficiency is just a fact that is good. The body has developed that in evolution of 100,000 years, protecting the body in these situations and taking out the iron from the circulation. And that is a fact. The thing is, I don't care if there is hypochromia, if the patient have good hemoglobin. And that is what I recommend you to do. I am not promoting you to do a new treatment, just to be more cautious with the iron and look the results and wait to see the hemoglobin if the hemoglobin is good. And you can measure the iron in the bone marrow, but will be the same, because I expect to be the same. Okay, but the ferritin will be decreased, and the hemoglobin will be the same. The patient is healthy. The patient don't have diabetes because it's a complication of iron overload. The patient will not have problems of the iron overload and hemochromatosis. We need to see the global thing, not only the red cells, our niche. We need to see the whole thing, as we did with Rajmilovich. We did a T2-star, and all the organs were full of iron. The liver was full of iron. The proton beam was going down in this patient with 6,000 because the liver has some cirrhosis. and have, a lack of production of proteins. We don't have to see our parcel, that is the red cells. We need to see the effect of this therapy in the whole body. And that is the lesson. Remember this, and I will send you the article, a copy of a reprint of the article if you need it. Think in this T2 star and think of the consequences to keep your transferrin saturation higher or your hypochromic red cells lower. I like hypochromic. The patient showed me that the patient will respond to erythropoietin. If somebody discover erythroferon, how to give it with low cost, give erythroferon. And you don't need to give erythropoietin. Erythropoietin is more than a growth factor. We know erythropoietin can stimulate the tumors too. And that is published by a Swiss guy that was criticized as crazy for the pharmaceutical companies. But the thing is that I care about the whole thing. The diabetes, the impotence, the males present impotence when they have iron overload.
May I say something? I'm sorry, but I have done a lot of bone marrows on CKD patients. And what I have observed is that they do have hypoplastic marrows, but they have lot of iron storage in their bone marrow. So I was attributing this to the fact that they undergo a lot of transfusions. While the hemoglobin is still 5, 6, 7, and probably they have this. But now that you have given us a new perspective, maybe I would like to look at this perspective. They always are getting erythropoietin though. Most of these CKD patients are on erythropoietin. But like sir said, maybe the validity of giving iron along with erythropoietin, I'm not so sure, sir.
But
I mean, after what he is saying, maybe I would look into this. Because I have always seen that the iron storage is always more than grade 3, 4, 5 also.
And please publish your results, because in one meeting in the meeting with the experts at 7 a.m. in the morning in the ASH, Auerbach was humiliating a person like you that said the same. Said,
No.
I found iron overload in the bone marrows, and Auerbach was humiliating this person in front of everybody. For this reason, we need to publish this data, and we need to publish any evidence that support that. That is very conservative. Yes, be more conservative with iron, but any evidence, please publish it.
No, what she means is, irrespective of the etiopathogenesis, majority of the patients of chronic renal failure, if you do a bone marrow aspirate or a biopsy, will demonstrate increased iron. That is there. The iron is increased, irrespective of etiopathogenesis, whatever it may be. So therefore, but still they may have hypochromia, still they may have iron deficiency, because that will be a functional deficiency.
Yeah.
That is what.
And the functional iron deficiency is treated with erythropoietin, not with iron. This is the final take-home message. Okay? This is the final take-home message. And please double check it. Next year, you will tell me you were wrong or you are right, or I will like your feedback, please. Thank you.
Thank you, Dr. Ramon. Dr. Ramon, may I request you to be on stage, please? We would like to felicitate you. Sir, may I request you to please be on stage? Thank you, sir. Sir, ka. May I call Dr. Haridas to felicitate Dr. Ajay Shah, please? Thank you, sir. We have an initiative from Mindray that's Lab Vision 2030. So we would like to introduce you to that initiative, and I invite Mr. Nikhil Panjwani to do the same.
Check.
Post that, we have a website, that's cubesummit.org, which Mr. Nikhil will introduce you to, and we'll have a short video for that. It's just a 1 minute video, and we would like to introduce our website that contains so many things, and we all can go
Okay,
through
okay.
it. Thank you. Over to you,
Okay.
Nikhil.
Okay. Thank you. Okay, first of all, thank you. I'll just make a small announcement before I go to the initiative. We have actually on your tables, we have this QR code for you. So whatever pictures you all have clicked outside today in the gala dinner, everything will be available on this link. So you just have to scan this QR code, just enter your maybe email ID or phone number, and then you can just check all your photos, what you have taken today. Thank you very much. And yeah, before we move on, I would like to introduce our new initiative, Lab Vision. Okay. Thank you, everyone, dear valued customers and friend. Thank you very much for being part of Cube ECTC 2024. Uh, while we are empowered by the transformative tools such as AI and big data in the diagnostic field, we are mindful of the challenges lies ahead. So Mindray is very excited to introduce a new initiative in our CUBE event, which is Lab Vision 2030. So under this initiative, Mindray calls all the laboratory experts and industry associations to collaborate with us in shaping a smarter future for better patient care. By leveraging tech-driven solutions along with the power of AI and IT, we aim to advance the laboratories in three key areas. The number one is greater efficiency in laboratory management. So that's why we call beyond management, and enhanced accuracy in diagnostic testing. So it means beyond diagnosis, and more sustainable approaches to education and talent training. So we are going beyond education. So through this comprehensive framework, we can unlock the power of data-driven insights to evaluate and increase the productivity and accessibility of diagnostic services. We look forward to partnering with all of you and realize this vision for the better future. So may I please request a small video of Lab Vision 2030 for you to understand more about it. Thank you very much for being a part of Lab Vision 2030. Now, can we move ahead with the next launch? Yeah, so this is our one more initiative when we come back to Cube. So as Shama ma'am and Dr. Handu sir mentioned, this is our 7th year of Cube. And even now, as we speak, we are a limited people in this hall, but more than 3,000 people have joined us online via Zoom, YouTube, website. So, Cube has achieved great heights under the guidance of Dr. Handu sir and the entire faculty here. Basically, what we are trying to do is we have been working tirelessly to enrich the content that we produce in Cube, and we have tried to make all the content that all the dignitaries like you, all the faculties like you have shared in the past 7 years. We have tried to make it accessible to all those who would like to learn from it. So we would just like to take a glimpse into the next exciting chapter. So please enjoy this small video all about our new website, cubesummit.org.
Thank you, Nikhil,
Thank
for
you.
your
Thank you.
like such a good job and entire Mindray team, in fact, for all this. We have been working very hard for uplifting the subject, the hematology analyzers that we have. And with your support, we have been able to come here. Especially, I would like to mention the mentorship of legends in the industry like Dr. Handu, Dr. Sukesh Nair, Dr. Ramon, Dr. Tajinder. It's been a wonderful experience through these 7 years. So thank you, everyone. And thank you, Nikhil.
Thank you. Thank you. Please do visit our website and share interesting content. Thank you.
I would like to make one more announcement. We will like to have a group photograph now. Before we start our next talk, we would like to have a group photograph. So I would request everyone to please come up to the stage for the group photograph, please. Thank you.
Okay, okay, you continue.
Come on, you're missing.
किताब है किताब दिया है जिसको मैं पढ़ पढ़ गया तो सर यही है उसमें पढ़ पढ़ गया उसको ही पढ़ पढ़ होता मैं पढ़ पढ़ जाता हूँ
लाइन कर लो लाइन कर लेते लाइन
एकदम परफेक्ट टाइमिंग कराली परफेक्ट टाइमिंग कराली फोटो मध्ये आला
And then the guy was a wrestler.
Check. Please do scan the QR code for this group photo and all other photos also. You just have to register with your mobile number or maybe email ID. Thank you. So the app will actually shortlist all photos in which you are there separately and all the other photos in a separate folder. So you can easily download it. All your photos, you can easily download it with just a single click. So please do download and scan the QR code and download. We are just starting in next 2 minutes. We are waiting for the speaker. The next talk is by Dr. Ashwini Sen Gupta on normoblast in low birth baby.
Selfie. session, sir.
The next session is starting shortly. May I request Dr. Ashwini Sengupta? And may I request Dr. Nitin Dayal to chair the session, please? On karna.
So without any delay, we'll start the session. So Dr. Ashwini Sen Gupta, she's NABL lead assessor, NABH blood bank and hospital assessor. She's trained in ISO 15189 since 1 decade. Faculty for DNB, DMLT and state medical faculty for West Bengal. And her academic interests are in hematopathology and breast oncology. She's a chairperson for of IMA Bengal State, and she has contributed in several peer reviewed journals. So, Dr. Ashwini, please.
Thank you, sir, for that introduction. And thank you all the stalwarts, right from Dr. Shukesh Nair, who has been the inspiration. I remember the first time he was like, why don't you do some work on the platelets? Because I get so many Bengali patients over here. So he has been the first inspiration in starting some research work in hematology way back then. I didn't have the amenities so much. And then from going to Vellore to his conference to now being every year a part of Cube for so many years now has been a great learning experience. So in my own way, I'm trying to just contribute to whatever little work that I have managed to do, though small, but I hope to achieve some more work. This subset of what the work I'm going to present today is just a subset of the ongoing research work that I'm already doing in the neonatal population in my hospital. We have an excellent NICU and PICU unit with great work being done. So I thought, why not use the opportunity to work on this thing. So we have an ongoing research on neonatal sepsis. This is a part of that subset of that ongoing research. So my topic today is on normoblasts in low birth weight babies. Now, low birth weight babies is defined as those which are less than 2,500 grams. Everyone knows that of the gestational age. But along with that, now we have the definitions of very low birth weight, which is less than 1,500 gram, and extremely low birth weight, that is 1,000 grams. Now, these definitions probably earlier were not so much in this because the outcome of these babies were not, but with improved modalities, I think more and more these babies are being seen in a hospital setup. Apart from this, we need to know the terms, that is preterm. All the babies born before 37 age is preterm, but also there are terms of very preterm, which is when the babies are born less than 32 weeks of gestational age, and extreme preterm when they are born before 20 weeks of gestation. Now, why it is important to know about low birth weight babies, or why the study on low birth weight babies? Because it's the single most important factor determining the survival chances of the child, and in the NICU or outside, and 2/3 of these babies are preterm. More and more incidents of preterm babies is being seen as compared to because of the more and more evolving treating modalities where the survival of these children is improving. So UNICEF WHO on low birth weight babies stated that the prevalence in South Asian states is 26.4%. And in World Health Assembly, they have taken a goal of reducing the this thing of by 30% worldwide by 2025, which is a daunting, because the figures now are nowhere near the achieved goal or target. The prevalence of low birth weight in India, the National Family Health Survey, which is the latest study which is published on 2023, has shown that 1/5 of the infants had low birth weight. And the incidence is 17.06. This is the average in certain states, especially the central states of India. And that includes most of the metro cities like West Bengal, Maharashtra, Gujarat, the central part, UP, MP, Punjab, Delhi, and also the central part of MP, Uttar Pradesh. All these states have even higher incidence beyond 20. So children with low birth weight baby, why it is important to know about them? Because they have a fourfold high risk of neonatal death. So it's their management which is important. And advancements in medical technologies now have enhanced the survival rates. But at a cost. That is, because of the advanced management, there is increasing health cost management and a financial burden that comes along with that. And these low birth weight babies are also susceptible to more longer stay in hospitals. So a more financial burden to the parents, to the society at large. These low birth weight babies also tend to have a lot of comorbidities associated with the low birth weight, from the central nervous system like lethargy, inactive. There are interventricular hemorrhage, cardiovascular. 1/3 of them are supposed to have a patent ductus arteriosus. Respiratory, they come with infections, respiratory distress, atelectasis, pneumonitis. Gastrointestinal, there is intolerance to feed, and then hepatic immaturity is leads to hyperbilirubinemia. So most of them have a neonatal hyperbilirubinemia. Jaundice, not all, and not all probably required phototherapy, but it is universally seen, and they are all prone to the most important comorbidity, that is infection. So either most commonly as the early onset neonatal sepsis, and sometimes even late neonatal onset sepsis. So normoblasts, what we are trying to study here is the importance of normoblast as erythropoietic progenitor cells, which are present in the bone marrow. They are not present in the peripheral smear of an adult, but in children, and not even in the children. In neonates, they are present, but still they can be a significant biomarker to indicate to the hypoxic and inflammatory injuries and the stress, and they can be a predictive for adverse outcome. Like sir has already said, that the basic idea of this conferences or seminars is for the clinical utility. So the idea of this study was also to improve the clinical utility of this day-to-day marker that we normally see in our analyzers. So we had in all 80 low birth weight babies, those which were born in a hospital. We have inclusion was those which were admitted in our NICU, while those which were admitted from outside were excluded from the study. And the estimated normoblast in the CBC samples within 24 hours. We all know that as compared to the adults, getting the blood from the neonates and then analyzing and over a period of time becomes a challenge because of the fact that the especially in very low preterm and extremely low preterm babies, where the amount of sample can be very small, and then correlate these normal NRBCs or normoblasts as inflammation markers with the comorbidities, and to have associate and find out whether it can be a predictive marker for a clinical outcome of the babies. So we have done automated normoblast counts are available. We have the Mindray BC 6800 plus, where all the birth CBCs were run on the CDR mode, and a manual verification always was conducted. As again, sir, I do would say that I love to look at the smears and would always miss if I don't get to see a single smear. So looking at the smears is always a pleasure. So manual verification of every count is done in our center and reported as per 100 WBCs as per norms. Correlation of the findings were made with the clinical history, the length of stay of the baby in the hospital, and then associated comorbidities. A correlation was also made between the automated counts and the manual counts that are done, and association was attempted with HNR percentage, but this is still for further studies between HNR percentage and LNR percent. This is yet to be completed to be next year, probably. So among the 80 neonates that we had, 48 babies did not have, though they were low birth weight babies, did not have associated comorbidities. So the length of the stay of these babies were hardly 3 to 5 days at the max. And among these, and 32 of them had comorbidities associated with the low birth weight. Then of these, the term babies were nearly 21. 5 of these were IVF pregnancies, an increasing trend now that we are going to see. Also, IUGR, we saw 5 cases of IUGR, 4 of which were confirmed with placenta biopsies in our hospital. Twin pregnancies were nearly 7 of them with increased IVF. Twin pregnancies have become more of a norm and a common factor. What was importantly seen in this study was that there were many maternal high risk factors which was contributing probably to the low birth weight of the babies. Most common of them were diabetes, hypothyroidism, per vaginal leak of the amniotic fluid, where in 2-3 of them there cervical encirclage was done prior to the delivery. Also hypothyroidism was found in few of the mothers. And even one mother had a brain SOL. So the low birth weight baby was because the mother already had a brain SOL in the posterior fossa. So the emergency LSCS had to be performed, because it is seen, we had two such cases where because of the maternal hormones, the brain SOL tends to swell up and create more symptoms in the mother. And of course, pregnancy induced hypertension also is one of the correlations. So all these maternal high risk factors were seen in nearly 20 of the 32 babies with comorbidities. And almost all, 100% of these 80 babies of low birth weight were found to have neonatal hyperbilirubinemia. All of them have increased bilirubin, but not all required phototherapy, because unless it is clinically symptomatic or beyond the threshold that we know of, sometimes not just 14, they give the phototherapy even at 12 or 10 if there are clinical symptoms and the baby develops the jaundice after, say, day 3 or 5. So phototherapy was given in almost 25 of these babies. So the observations what we had was among these 80, 21 term, 56 were preterm, of which only 3 of these were very preterm. And 80 of these 2 were extremely low birth weight babies. And while 11 were very low birth weight, the other most of them were only low birth weight. And the most important aspect was the length of stay of the babies when they didn't have the comorbidities was that of 3 to 5 days. But when their low birth weight babies, the average length of stay was found to be almost 19 days, and which ranged from nearly 5 to 45 days, 41 days. So these were the findings that we saw among the this thing. The length of the stay, like I said, 3 to 5 days. Those with complications had the most common complication or comorbidity disease that was associated with low birth weight baby was that of sepsis. Almost 29 of these 32 babies had sepsis, either early onset, most commonly early onset neonatal sepsis, which was found in almost 26, while 3 were having late onset neonatal sepsis. But only 5 of them had proven culture positive, but all of them had sepsis screen positivity. And after treatment, when the sepsis screen was negative, then onwards the discharge of the patient was found out. I think I went back. Yes. So among the very preterm and very low birth weight, we had 3 such babies where the birth weight was less than 1,000. One was 755, one was 800, and the other was 800, one of which had IUGR. We have also done the placenta biopsy of this patient. All of them had respiratory distress syndrome, and all these 3 had, one had late onset, but 2 had early onset neonatal sepsis. And as you can see, the length of stay in these extremely low birth weight babies is very high. And the normoblast percentage also, if you can see, compared to what is there, which I'll show in the subsequent slide, is high. Here, in fact, the one with 800 grams had a normoblast of 115, and one with the LOS of 43 days, along with the sepsis, this baby had a cardiac problem of TOF. So the normoblast percentage here was very high. This normoblast percentage was done on the first within 24 hours, and that we feel corroborates with the higher comorbidity of the. So among the 11 babies which were very preterm, the length of stay was 19, and sepsis was found in most except of one of the twins. Both the twins were admitted, but one twin had sepsis while the other need not, but both were low birth weight babies. The table format is there as to give the normoblast percentage. If you can see the average percentage of normoblast in these babies is almost 34.8 as compared to the normal, which is less than 2. And all these babies had respiratory distress syndrome, all of them except one. All of them had neonatal hyperbilirubinemia, 4 of which were IUGR, IVF. One had tetralogy of Fallot, and one had patent ductus arteriosus. And I had already told about the maternal factors. The preterm low birth weight babies with no associated diseases had a normoblast percentage of only 0 to 2 with an average of just 0.48. So in spite of neonates having the normoblast, the percentage in the peripheral smears is very low. And in preterm babies with comorbidities or diseases, the average goes much higher. This is low birth weight babies, not extremely low birth weight or very preterm, just very low birth weight babies, just low birth weight babies, that is between 2,500 to 1,500. There the average normoblast percentage becomes 5. So you can see in low birth weight babies, the average normoblast percentage, so in normal, without associated, it is less than 2, an average of 0.5. Of more than, in low birth weight, it is average of 5. In very low birth weight, the average goes to 24.8. And in extremely low birth weight babies, it goes even higher. In though the one baby had just 12 and the other babies had 600 and 115. So as the low birth weight is more extreme, the number of normoblast percentages is also there. Also, they also have increased association and more comorbidities, the most common of which is sepsis. We also correlated the WBC and automated normoblast percentages for the in septic babies, and there was a high positive correlation with a mean normoblast value of 40 as an average in all the uh, low birth weight babies. We have also correlated the, like I said, automated and the manual counts, and there also the Pearson coefficient is found to be 0.97, which is high. The only observation is that the reported normoblast percentages, we always report them as per 100 WBCs. It is slightly lower always than the automated, which tends to be higher because we always round it off to the lower side as compared to the automated, which is in point and decimal points. So to summarize my talk, elevated nuclear red blood cell within the first 24 hours can be a predictive of severe morbidity or adverse outcome, so that this could help in the clinical utility of management of this patient, knowing that these patients are going to stay in the NICU for a longer time and would need more management, especially from sepsis point of view, which is a single most important complication which was seen in low birth weight babies. And of these 80, the length of stay also was increased from in normal without comorbidities from 3 to 5 to nearly an average of 19 days. And there was a good correlation between automatic and the microscopic estimation of normoblast, and a high positive correlation between increasing ranges of WBC and normoblast in sepsis. So that's to summarize my talk. Thank you all. So if you all have any kind of a question or queries, I would be happy to take some questions.
Any question? I just wanted to ask you, did you correlate these NRBC according to the time of like how much preterm baby was there, or you just analyzed it according to birth weight only?
Birth weight and preterm both were, I had given the data of preterm also, from preterm, very preterm to extremely preterm, though those data were also given. So those which were two of those extreme low birth weights babies, two of them were extreme preterms. One of them was IVF pregnancy, one of them was IUGR.
Okay.
So there are different permutations that we have seen in our study. But IUGR, IVF, and maternal factors do seem to be the most important contributing factors to low birth weight babies.
Any questions? Any other questions? I think no. So may I request Dr. Nitin Dayal to hand over the memento to Dr. Ashwini and felicitate her? Sorry. May I request Dr. Deepak Sadhwani to please come on stage and felicitate Dr. Nitin Dayal? Thank you, sir. Thank you very much, Dr. Ashwini. So moving on to the next talk for the day, I say evening. May I call upon stage Dr. Asik Siddiqui? And may I request Dr. Deepak Sadhwani to chair the session, please?
Good evening, everybody. Dr. Asik, our next speaker. He has completed his MD from Kasturba Medical College. He has long teaching experience and multiple papers that he has published. At present, he is working as the Prof and Head of Department of Pathology at MES Medical College. Without any delay, Doctor, please carry on with your speech.
Thank you, sir. Thank you for your kind words. First of all, I thank the organizers invited me to take this topic over here. And Dr. Sharma has requested me to shorten the presentation, right? And to I'm not able to. Calm down. Yeah, yeah. When you enter to the emergency room, almost all the department people will be doing lot of calculation and uh, evaluation, all those things. I done certain studies in hematology in the emergency room. One among is that it is the IRF in different critically ill fever patients. So IRF, as all we know that it is an immature reticulocyte fraction. It's a relatively a new reticulocyte parameter available in a automated instrument. It assesses the maturity of the circulating reticulocytes, and it's quantifying the fraction that stain the strongest among the strongest of RNA. And IRF factor has significant clinical application in hemolytic anemia. We can know about the regeneration and non-regenerating conditions, we can assess it. And here what I done I done it on the fever in a critical patients. And it assess as all we know, the reticulocyte maturity can be assessed by the IRF, whereas the absolute reticulocyte count for severity of the anemia can be assessed. But when you combine with both, you can assess total marrow erythropoietic response can be assessed. The aim of the study is to hypothesize that IRF could provide a diagnostic information to evaluate and management of patients with infectious conditions like dengue, lepto, H1N1, and COVID-19 being evaluated. And specifically, the IRF quantify the fraction of circulating erythrocytes. And the marrow excites and at least mature, we speculated the changes in the IRF and changes seen in the reticulocyte count in the infectious crisis and its recovery phase also. A big change in the values we are seeing it. And the method, I studied about 88 cases in a critically ill fever patients in an emergency room, which came in our hospital during the period of 2023 to 2024. And total of 44 dengue patients were there in it. And 20 were H1N1, and 16 were COVID patients, and 8 were the leptospirosis. And we studied the reticulocyte indices were measured in Mindray 6800 plus automated cell counter. These values were analyzed and correlated with biochemical and serological and molecular and compared. A lot of analysis we have done it. The cases was stratified into different etiological group also, like these infectious conditions. The result you can see here in a fever, different stages of fever, like in acute phase of fever and critical case and recovery phase and convalescence phase. You can see here in a dengue, lepto, H1N1 and the COVID. In the dengue, very low IRF value is seen. I have given a very wide range of IRF value, that is 1.1 to 11.4, and it is not standardized as such. So with a mean of 4.7%. Look at here, leptospirosis and the H1N1. There is no lower value is not. That you can see it in the even though the in dengue patients is showing a very low value of IRF. So in a dengue viral infection, it affects the thrombocytopenia, it affects the thrombocytosis, but it's also affect the erythropoiesis. It's not lowering, is it? It increasing the HB percentage and the hematocrit will be increased. So it is not, is it really affecting the production? I doubt about, there is no, it is not affecting the production of, so IRF is very low in this case. So simple hematological parameters with IRF, you can expect to be able to indicate how active the erythropoiesis in bone marrow in these infectious conditions. And these are my values in different fever cases. I mean, in dengue patient. And the IRF in the fever phase is lowest, and compare with the other phase also. And the critically ill patient also, it is normal. Around 4.7 low only, but not as low as the dengue patient. So in conclusion, IRF is a newly routine parameters in hematological analysis, the retic mode, and which gives an idea about early morphological change in the marrow. So need to evaluate dengue patients, the suppression of bone marrow either directly due to the cytokine or high RBC count and high hemoglobin can reversely suppresses the IRF. And this, I don't know, we need to do the cytokine analysis to differentiate these conditions. This cause of the suppression of IRF. And that's my message to this talk. Thank you.
Thank you so much, Dr. Asik. Anyone has any questions to ask, please?
No, sir.
Any questions?
Among this
Among
audience,
this-
how many of you use IRF?
We use it mainly used for hemolytic anemias.
No, you presented. I'm
Okay.
asking the rest of the. IRF had a lot of promising data when bone marrow transplant started.
Yeah.
But nobody was interested in IRF because in bone marrow transplant, the most important cell is the neutrophil, not the red cell.
No,
Red cell you can transfuse. Neutrophils you have to produce to prevent infection. So IRF never got promoted as a parameter the way it should have. Because I know the people who develop IRF, Sam Machin, Bruce Davis, they still talk about it, but it never got promoted as a parameter. But IRF should be used primarily by us to differentiate between certain type of hemolytic anemias.
Hemolytic anemia, it is very useful.
So, how to, as an approach to see, recently I was dealing with, discussion of a group of anemias. Everybody does CBC, they look at MCV and all those. Obviously, MCV in anemia is very important. But managing anemia without reticulocyte count is a non-starter. So when you start managing anemia, you have to have hemoglobin, you have to have MCV, RDW, and reticulocyte count.
Reticulocyte count is mandatory.
So reticulocyte count is very important in management of any anemia, whether it is iron deficiency anemia, whether it's megaloblastic anemia, whether it's aplastic anemia, whether, you have to, in the beginning investigation, you have to have reticulocyte count.
Right.
In fact, even manually also you can identify IRF.
How, sir?
Come on, yeah. It's very simple. Look at the reticulum in the red cell.
Reticulum
You
is
can
cells, right.
classify, so many reticulum, 1 plus, 2 plus, 3 plus, 4 plus.
But
4
but
plus,
it is
4 plus is
subjective, no,
4
sir.
plus and 3 plus is your IRF.
Yeah, it is subjective, it is not quantitative, is it?
Maybe.
Maybe.
But I'll tell you one thing. Manual reticulocyte count is definitely inferior to automated reticulocyte count, especially when the reticulocyte count is in the other side.
Okay.
So when you talk about manual reticulocyte, actually it overestimates IRF.
Okay.
Like, for example, you can't have IRF in cell counters which does new methylene blue. Because new methylene blue, the immature, the most high reticulocyte portion will never get counted as high reticulocyte. It will be counted as a low reticulocyte because the light scatter is very low.
Yeah.
But they are actually the highest reticulocyte count. So there is a lot of variability. So you can actually look at manual reticulocyte count also to identify, difference between hemolytic anemias and other types of anemia. But IRF may help in identifying, differentiating anemia from hemolytic versus non-hemolytic. That's all. Otherwise, it has no role.
No role, is it? No infectious conditions, there is
Nothing.
no.
No
But
role.
my idea here, why in dengue it is less?
So, yes, not only dengue, there was a lot of paper that came up in not only dengue, in sepsis, in basically SIRS. In SIRS, how does RDW predict morbidity in ICU patients? Reticulocyte is the main cause for that. That's the main cause for that. Makes the difference in RDW.
Yeah, correct.
But every observation is very important. and very happy to see you are also observing this.
ARF in infectious conditions.
Thank you
Thank
for
you,
that.
sir. Thank you, sir.
Thank you very much, sir. May I request Dr. Asik Siddiqui to please stay on stage? May I request Dr. Deepak Sadhwani to felicitate the speaker? Thank you, sir. May I request Dr. Haridas again to please come on stage and felicitate our chairperson? Sir. We move on to the next talk now. May I request okay. May I request Dr. Prashant Gupta to please come on stage? And may I request Dr. Haridas to chair the session, please?
Ready? Hmm?
Welcoming Dr. Prashant Gupta, Director of Prashant Prasad Path Lab, Palwar. I'd like to introduce Dr. Prashant Gupta to everyone. Founder member of Association of Practicing Pathologists in Haryana, and organized more than 13 conferences in Haryana, running his own lab, KC Prashant Lab, in Palwal, Haryana for the last 20 years. Started National Community for Use of AI in Pathology and has successfully conducted many webinars on this platform. Has helped in establishing of medical colleges in Haryana. Has established many blood banks and keen interest in blood banking. Patron of Indian Red Cross Society and organized more than 4,000 blood donation camps. And providing free blood to more than 35 thalassemia kids every month from his own blood bank. Welcome, Dr. Prashant Gupta, to give his talk.
Sir, thanks for the kind introduction. I am going to present the use of immature platelet fraction in daily use of our laboratory. So I am coming from the KC Prashant Path Lab, situated 60 kilometers south of Delhi. It's a small town, which is having a population of 10 lakhs and in an area of 40 square kilometers. KC Prashant Path Lab was started by the inspiration of my father, Dr. Shri KC Gupta, who supported me in each of my endeavors. I have stated art blood bank to support thalassemia kids and people of Palwal. Sir, IPF, we all are talking about IPF. You all know these are the portions of young immature platelets in the peripheral blood. It is a measure of reticulated platelets, platelets which contain mRNA in the peripheral blood. It helps to track the thrombopathetic activity of the bone marrow. It increases when the platelet count increases and decreases when the platelet count falls. So there are various causes of thrombocytopenia, as all of you know. The cause may be platelet destruction by the dengue or immune system, or sequestration in the spleen, and the third is the platelet production impairment by the bone marrow due to immune process. So reticulated platelet is the new generation hemocytometer parameter, which helps to differentiate between the peripheral and central etiology of thrombocytopenia. So newly formed platelets are more reactive than mature platelets due to high granule content and contains the residual RNA derived from the megakaryocytes. So the reticulated platelets extends the possibility to establish the diagnosis of thrombocytopenia, whether either it is increased platelet consumption or bone marrow failure, without doing a bone marrow examination, which is both invasive and painful procedure for the patient. So we selected 5 cases, random cases of thrombocytopenia, and studied their IPF, MPV, and platelet count. We found a good correlation between the IPF and platelet count. We did our study on the BC 900 and collected sample in K2 EDTA. CEO can find that here, in all the 5 cases, the platelet count is decreasing and the IPF is increased. So we could surely tell the patient that you don't need a platelet transfusion right now. You can wait till tomorrow or so. We could avoid platelet transfusion in all the cases except that number 2, because the platelet count was so low, they could not wait for more. Another case was an incidental finding in an alcoholic male, where we found a sudden fall in platelet count in routine checkup. The patient evaluation was done and vitamin B12 was found low. Vitamin B12 injections were given and there was a gradual improvement in the platelet count. So here is the series of platelet count and the IPF. You can see on 27th, it is 60,000 with the IPF of 6%. Vitamin B12 therapy was given and the platelet count increased along with the IPF level. And when the IPF was maximum, within 2 days, the platelet count also was maximum, which returned back to normal after the stoppage of therapy. Fibroscan was done in this patient, which showed moderate fibrosis. Elevated liver enzymes were seen and patient was diagnosed with chronic liver disease with thrombocytopenia. So the IPF can be used to differentiate the spectrum of chronic liver disease, whether it is hepatitis or cirrhosis. We found a nice study on this use of IPF in chronic liver disease. This is a flow cytometric analysis where we can see the IPF is seen here. So my point is that platelet and IPF can be both prognostic and diagnostic marker in various clinical settings. It can be helpful in differentiating the increased platelet destruction and decreased platelet production in different conditions, and to monitor the effectiveness of treatment for thrombocytopenia, such as corticosteroid or immunosuppression therapies. We can use it when the platelet count is low in cases of ITP, DIC, TTP, or myelodysplastic syndromes, or where the platelet count is normal or high. We can use it in different conditions where altered platelet function is seen, like in acute coronary syndrome, chronic uremia, or miscellaneous conditions are there, like chronic liver disease, ICU patients to analyze the sepsis, and neonates and diabetes mellitus to predict the cardiovascular events. So this is a pictorial depiction, like IPF was increased in all these conditions, and which can guide us regarding the adverse outcome. So few of the studies with the IPF along with the diabetes mellitus and cardiovascular complications, or use of IPF in which is correlating well with the SOFA score in sepsis patients and other diseases. So my point is that we can use it in different conditions where the chemotherapy or stem cell transplantation was done. It can be used to gain insight about the platelet function. It can be used to predict the bleeding in patients with thrombocytopenia. It is a early detection of preeclampsia or HELP syndrome. It can be used to determine whether the platelet thrombocytopenia requires a platelet transfusion or not. It can again be used to evaluate the transfusion effectiveness and in sepsis and critical illnesses patients also. So IPF can be used as a non-invasive marker in place of bone marrow examination and has multiple future possibilities which need to be explored further. Thank you.
No.
Any questions?
Thank you, Dr. Gupta, for
Thank you,
the
sir.
brief and well-researched talk. Any questions from anybody?
Sir.
So, Dr. Gupta, I think one of the most important statements you made today eclampsia and help, because it's a very important data which we can help obstetricians with. Because in obstetrician, they keep on, I actually recently attended and I was a speaker also in a program in Jipmer. It was about missed events in obstetric accidents. And every talk was about, eclampsia, obviously diabetes was also part of it. But, if we can use that information, that IPF can be an useful data in patients with preeclampsia, that's enough. Of course, the rest of the part doesn't matter. But in preeclampsia, if it's useful, it's a very useful information.
Yes, sir.
Help is good because, recently we had a patient who actually had help, but the obstetrician insisted it was TTP. And the patient went into acute fatty liver of pregnancy. If they had actually understood that this patient had help, they would have managed the patient differently. Now the patient is dialysis dependent. See, thing is, just imagine this is CMC Vellore, where there's availability of Adam TS13 assay 24/7. TTP, you can rule out TTP in no time. Schistocytes, oxidant hemolysis is a problem. The schistocytes, keratocytes is not easy. But the fact is that, and at one time when we didn't have Adam TS13 assay, we'll say schistocyte. Now we have got Adam TS13 assay. It's more specific. When you say that it's not TTP, they're still persisting on. So I think, it's a very good information that you've given us, Dr. Gupta.
Thank you, sir.
I think all of us should go back to our places and see whether this data is very important in patients in preeclampsia, eclampsia, and health.
Because we keep on talking about IPF in relation to dengue only, actually.
That we have to find out. Yeah. I won't give the mic to you.
Yes.
There are places where it is important because we all are focusing only on the dengue only.
Yes, sir.
But there are so many hidden information is there with the IPFs. We need to evaluate this.
Any other questions, please? Thank you, Dr. Gupta. May I request Dr. Haridas to please felicitate our speaker? May I request Dr. Ashwini to please felicitate our chairperson? Sir, may I request you to please stay on stage? Thank you. Thank you very much. May I request our next speaker, Dr. Vishu Bhasin, to please come on stage. And may I request Dr. Mohan Galande to please chair the session, please.
Let me introduce Dr. Vishu Bhasin. He's head and director of Dr. Basin's lab in New Delhi. His topic is evaluation of ESR in cell counter with transitional method. He's done his graduation from Manipal College, Medical Science. He has special interest in exploring newer technical integrations and IT solutions for lab management and efficiency. Okay.
Good evening, everyone. So I'll be discussing about evaluation of ESR cell counter versus traditional methods. This is more of an academic based topic than a research based topic. And we've been using the BC 700 series for nearly 2 years now. We started off with the one without the autoloader. Now we're using the both. And based on that, I'm having this discussion. So for a short introduction, we all know ESR, it's a widely used but non-specific marker for inflammation. It is the rate at which RBCs settle in an anticoagulated tube over an hour. It's a process influenced by plasma proteins, particularly fibrinogen and other acute phase reactants. The utility spans over various disciplines, including rheumatology and internal medicine, but it aids in monitoring and prognosticating numerous conditions, not diagnostic at almost all places. So, a brief about the history. It was first described by Edmund Bernanke in 1897, and later in 1921, when Westergren standardized the method, it came into clinical utilization. It has been staple test in labs for decades, but recent advancements are opening new perspectives how we approach this test. Because honestly speaking, as a pathologist who would have passed out in last decade only, the clinical applications and standardization of ESR was becoming more and more challenging. However, such technologies are making them easy and making quality control better for us. Talking about mechanism of ESR, there are three stages of it: rouleau formation stage, rapid sedimentation stage, and erythrocyte packing stage. So the rouleau formation stage is about 0 to 20 minutes, and rapid sedimentation stage is more than 15 minutes. So raised ESR is basically, in normal ESR is negatively charged, so it has a lower sedimentation rate. And during inflammation, the RBCs are less negatively charged as plasma proteins, gamma globulins, fibrinogens negate this charge. So there is a increased sedimentation due to increased rouleau formation. Talking about the clinical utility of ESR, because so it's in managing chronic inflammatory diseases like rheumatoid arthritis, SLE, polymyalgia rheumatica, and temporal arthritis. So this is basically to monitor the fall in ESR shows the treatment is working well and the inflammation is reducing. In infections, subacute and chronic infections, it has been our long friend in tuberculosis and one of the places where physicians still look at ESR. Rheumatology and tuberculosis are two applications where religiously ESR is still being used by physicians. Post-op monitoring, an unexplained rise in ESR may prompt further investigation. However, in clinical practice, I don't see surgeons and intensivists looking at this with that perspective. Oncologists, malignancies, yes, multiple myeloma, lymphoma, monitoring, oncologists are looking at really seriously and sometimes in unexplained weight loss as well. Same in a few solid tumors like renal cell carcinoma. This is again useful in monitoring than diagnosis. Cardiovascular disease, it's a theoretical mention I have kept here because it was there in the text, but there's nothing clinically that is being done. In CKD, yes, it is being used by nephrologists regularly in monitoring inflammatory complications and comorbid conditions. Coming to the limitations, it's non-specific. This is the biggest problem this essay has. I remember as a first year PG, I was making a list of reasons why ESI is raised. I think I covered 2 full pages. So it's getting affected by so many things. It's not specific. So, and in many conditions such as anemia, kidney diseases, ESR is often raised even in the absence of inflammation. So it is not completely specific to the inflammation also always. Delayed response, ESR rise and fall is slow. Now, parameters like CRP offer us a better sensitivity or procal for sepsis because their rate of rise and fall is faster. So ESR is not a good friend for acute conditions, but yes, it is a old friend helping still in chronic conditions. So limited use in early disease detection. External influences, it's a very sensitive parameter. With increasing age, the ESR values rise. In women, the values are higher and it even gets affected during menstruation. So for females in reproductive age group, this test is not so good. Anemia again increases ESR even in absence of inflammation. And honestly, in a clinical context, if I speak, a majority of patients who are presenting with tuberculosis are actually anemic also because TB is now more in the low strata. So, and certain medications also like statins and steroids alter ESR by influencing red cell aggregation. So these were the technical limitations, but the practical ones are that it's a subjective assay. The test is completely manual. It is operator dependent and environment dependent. So no matter how simple it may look, but we are completely reliable on technicians to fill the tubes properly and read it at exactly 1 hour. And it's become more challenging now because with everybody having mobile half the time, the technician who's on duty is waiting while he's put the timer. Earlier he used to use the timer in the lab. Now he uses his mobile and is seeing the reels. So whether he's reading at 1 hour plus minus 1 minute, it's really no way we are able to assure that. So it has reduced sensitivity in certain diseases. There it may remain normal despite the presence of inflammation. So for an SLE, where it has a very good application in looking at flare-ups, but it still remains normal sometimes. In AMI, ESR elevation is delayed. So, it's the person will pass away, so we don't even look at it for that matter. So talking about the reference range for males above 50, it is less than 20. Males less than 50 is less than 15, but a practical range is age less than 12, age divided by 2, sorry. For females above 50, it is less than 30, and for females less than 50, less than 20, but a practical reference range would be age plus 10. Special mention is markedly elevated ESRs more than 100 because ESR may have a lot of non-specific rises very often in general health checkups or CBC ordered for random, for any other reason. The raised ESR of 30, 40, clinicians often ignore, but ESR more than 100 actually warrants immediate attention. So what can be the conditions? Severe bacterial infections like pyelonephritis and sepsis, autoimmune vasculitis, malignancies like multiple myeloma and metastatic cancers, and connective tissue disorders, severe flares of SLE or rheumatoid arthritis. Now, this is where ESR was losing its significance, that on one side, an SLE, a flare up, it can go as high as above 100, but in few cases, it remains low. Now, as a laboratorician, it becomes a problem because clinician all does not remember the pitfalls of the test. He just thinks that every time my finding is not matching up, lab has made an error. So talking about evaluation through traditional methods, we all know the Westergren method. It is the ICSH reference method, a 30 mm long tube with 2.5 mm bore open on both sides at 18 to 25 degrees Celsius with sodium citrate of 4:1 dilution. We can use EDTA also as an anticoagulant. So that's called a modified Westergren. That's just for everybody knows that. And Vintrobe, it just uses a smaller tube, 11 centimeter long with 2 mm bore, and can also be used for PCV. Now, the limitations in traditional method is that it's time consuming, requires 1 hour to complete the test, which may be a limitation in acute care settings and where urgent reports are needed. Further, the time consuming is not just about conducting the ESR, it is complete comprehensive TAT of the patient, because CBC, for instance, the analyzer is taking 60 seconds, but it takes us an hour to give out even an urgent report. Likewise, the same in hospitals or big institutional setups, They are segregated labs, so multiple EDTAs may be collected. But for standalone labs, especially preventive health checkup, which form 25% of laboratory business by all data, we are just collecting one EDTA. So that the same EDTA we have to run CBC, then we would perform an HbA1c on that, and then it would go for ESR. So that really has a big impact on comprehensive turnaround time for us. Manual errors are immense because again, the labeling is completely manual. You are writing on a sheet across the stand. You have numbered the sheets. So there's in the current laboratory methods, we are moving more and more towards, we are almost completely at barcoded systems. So this is a human error is very high. Temperature sensitivity, sedimentation rates are very sensitive to temperature. And when we are looking at results, we are not just looking at results coming from our lab. It's not about, we have to answer to the clinicians. Say Pankaj sir was here, he's talking about Palwal. In Delhi, I don't have neighborhood of such labs, but in a place like Palwal, he would have a lot of people around which are unregulated labs run by technicians in one room who, would have a AC to probably run their CVC analyzer. But for ESR, they will never turn it on. And when those results come up, the doctor is asking us why they don't match. So anticoagulant issues, improper mixing of blood with anticoagulant, but that's sorted now with the tubes. And operator dependence and quality assurance is a big challenge in a traditional ESR. Coming to automated ESR systems, the first line of automated ESR systems which came were modified Westergren automated systems. So they generally what they do, they let the agglutination stage go on, because the sedimentation stage, it is a well-defined factor that rapid sedimentation happens at the same pace. So they let the agglutination phase get completed, take a reading in the early sedimentation phase, and calculate the net ESR value. However, now we are looking at capillary photometric ESR systems or a near infrared photometry technology, which Mindray BC700 series is using. So it is not relying on traditional sedimentation, but it assesses the erythrocyte aggregation in a small volume blood sample using optical sensors. So these systems, they are actually calculating ESR within first 5 minutes, say for Mindray it's 72 seconds. How they are doing it is they are doing it right in the aggregation stage only during the rouleau formation. So the Mindray BC700 series, I really take it as a boost for laboratory functionality. Single tube automated CBC with ESR. It's called a easy WESR technology. 72 seconds. It has really changed a lot of functioning in my lab. So the principle is that the rapid sedimentation stage, as I was mentioning, falls down with a constant speed. So which in turns, at the speed they will fall on, it depends upon the erythrocyte aggregation state in rouleau formation. So over here, they are using a dynamic curve to predict the 1 hour fall. What are the key factors it is using? Erythrocyte aggregation speed. What it's doing, the speed at which erythrocytes are clumping together is equal to the time required for the aggregate to form. And once this stage is complete, then it would go to sedimentation. So faster the aggregation is happening, there's early start of sedimentation and high ESR. That's where the red line is for the high ESR, as the sedimentation is happening faster. To achieve this technicality, there's one thing more they needed is the erythrocyte aggregation degree, because at the end, when it's falling against free flow with the gravity, it would fall at a constant speed, which depends upon the size of aggregate, which determines which would be determined by the degree of aggregation. For this, they have created a complete disaggregation of erythrocytes by high velocity laminar airflow, which is putting red cells in a shear pressure under a shear pressure, where it disintegrates any previous aggregation which may have happened in the samples. After that, it suddenly stops to capture the peak aggregation speed so that they come to normal morphology and start reaggregating. And that's where it takes the measurement of the aggregation happening. then the aggregates are looked, and sorry, they have a temperature module which ensures constant temperature. So the machine first is preparing the samples by the 3 steps I explained, and then through the light source, they are looking at the aggregation speed. Now, what it does, it has taken 2 measurements: aggregation speed, which tells the sedimentation start time, aggregation degree, which tells the sedimentation speed it is going, and it would put it into a distance curve, which would measure the value and give out. Clinical performance, as per the company, it has a 0.94 correlation. However, the same claim was performed by clinical validation by Dr. Kunal in India. 2 years ago, when we brought this and started reporting, we had done our validation with over 200 samples, and we had found complete correlation of almost all values. To talk about a comparative analysis of ESR manual methods, automated methods, and the ECWASR, it is the fastest amongst all. It has the lowest interoperable variability. Pre-analytical sensitivity is less because the scope of pre-analytical errors, because it's a primary tube sampling, barcoding and interface. So post-analytical errors also it is taken care of. The main question comes with technology is the cost. But if you ask me, in my 2 years of experience, by removing the traditional or the Westergren based, automated Westergren based ESR system which we were previously on, this is costing us much lesser when I account for manpower cost also. So advantages which I have seen in my lab, the TAT is faster, reduced human error, single tube assay, primary tube, barcoding and interfacing, reduced manpower requirement since it's a walkaway system, accuracy is better, space saving for standalone labs, space is a big decision, and definitely it gives us a better quality control and quality assurance. For the patient, we are not having to need extra blood sample, faster result. The wonderful part is, as ma'am was also talking about, neonate and pediatric and other low volume samples. We do a lot of work with NICUs and pediatric patients as well, but we were doing TNP for all ESRs over there because we never had enough volume to even perform on a Westmatic system. Urgent reporting is possible, and now the patients in serial monitoring who are undergoing a treatment for tuberculosis or SLE or rheumatoid arthritis, the comparability is much better. So in my experience, I have actually seen 0 errors as a primary tube sampling. In last 2 years, I have actually not received a clinician call me back and say, I'm not happy with your ESR result. So that's a big marker. I looked back when they asked me to have this talk, I looked back at my data of all the customer complaints and queries which come. None of them were with ESR. QC, QA and accreditation has become much simpler. My neonatologist is happy, my pediatrician is happy because they have this parameter which I was unable to report to them. And pediatrics is a special area, so the kids are happy with us. We are able to do. So from my end, it's a 5-star parameter, equipment and performance. Thank you, everyone. Any questions? So,
Yeah. Have you had during the experience that during the time that you have any case of a paraprotein or multiple myeloma or monoclonal gammopathy?
So I have a lot of patients of multiple myeloma which are on follow-up because we work with certain oncology centers. So yes, we have tested those patients and I have seen multiple times the ESR values of 148, 156 also for them on this system.
I am asking you because when I found customers like you that evaluate the instrument, some of the methods that are compatible for inflammation with the Western green, with the classical 60 minutes method, they are not able to detect paraprotein. And some other looks like all the customers that I have asked say the same. Yes, are also having higher sedimentation rate in case of paraprotein.
Yes, sir. This is my also experience in paraproteinemia. Majority time, this method may not give high ESR, So when we see mark rule in morphology and ESR normal, then we suspect paraproteinemia in that case by this method.
Can you repeat your
How many
question,
of
sir?
you have experience with people, physicians or pediatricians or obstetricians who are used to 20 minutes ASR, 40 minutes ESR, 60 minutes ESR?
So for physician perspective,
Wait. Has anybody got an experience with physicians like that? Do you have physicians who need report of 20 minutes, 40 minutes, 60 minutes?
no, sir, I'll tell you one
No,
thing.
I'm telling you, in your experience, whether your father or grandfather had experience of physicians who want 20 minutes, 40 minutes, 60 minutes ESR.
No, sir, let me answer.
No. Do you have experience with that?
Sir, let me answer.
No.
Sir, let me answer.
No.
Sir,
Yes
sir,
or
let
no?
me answer.
No. Yes or
Sir,
no?
let me answer.
Yes or no?
Sir, let me answer.
No. Yes or no?
Sir, let me answer.
No. Yes or no?
Sir, let me answer.
Yes.
Sir, one thing.
No.
For
Yes
physician,
or no?
sir,
No. The
physician,
question is yes or no.
sir,
The question
it's-
is not to you.
no, the question is not
no,
binary.
no. You're not supposed to answer the question. You are supposed to answer yes or no.
So the answer is not in yes or no.
No.
Please let me answer.
No. Then forget it. You don't have an answer. Do you have answer? Yes. Okay, fine. 1 hour and 2 hours. Okay, 2 hours is different. Anybody? Dr. Kothari? 20, 40, 60? You have. What's the answer for that?
Sometimes they feel that at 20 minutes and 30 minutes, certain collagen diseases or connective tissue disorders, because of the higher proteins, will have a difference in rate of sedimentation. So they make sure that we do it.
Now, suppose you're going to introduce this technique, how are you going to answer them? Okay, you heard that? So your question, the reason I asked that question is 20, 40, 60, yes or no, you are not able to answer. That basically means he's not able to, he doesn't have, what customers who are interested in that. I have got people who want 20, 40. First time I introduced automated ESR, I had 20 bedside operators who said 20, 40, 60, kahan pe gaya? They want that answer because they use, obviously, he gave a lot of, fortunately, we got a good introduction to ESR. Took a lot of our time, but it's all right. But we also know that you cannot use ESR as a diagnostic test. But there are bedside physicians who use ESR at least to differentiate and help their clinical acumen. So that's why I asked, you failed in that answer. 20, 40, 60, you are not able to answer.
So I'll tell you, I was answering.
No. I asked you yes or no. You said you can't answer the question. It's finished.
Let me say something because I feel a little bad. I think every clinician have its own experience. And for example, sometimes that they look like me expressing, I ask a morphological analysis of the CBC, even with a no flagging. And I ask for a manual differential. And they look like me like crazy. Okay, but they do it normally because they know me. And I look for myelodysplastic syndrome features or whatever. Okay, but we can do always. We have all of us. We have Western green capillaries, and we can do it if somebody asks for that. But the important is what we do for 95, 98% of the people that is asking that they don't need that. To have optional methods for people like me or others that ask for a method out of the SOP is okay. We can do this method for the majority of the people, but we can keep some Western green for the people that is asking that. I think I will answer. I never had anybody.
So Raymond, you don't know the practice in our country.
I know. But,
you don't know the practice in our country because wait. In my hospital, which is a fairly advanced hospital, I do 600 ESRs every day.
How many people ask for
and
that?
CRP? I do only 30 CRPs every day.
And how many people is asking for the 20 minutes? How many? Which
So
percentage?
they have, fortunately, they are retiring.
Okay.
Fortunately, they are retiring.
Oof.
For me. No, not who for you, who for me. Because I have been trying to bring in automation in ESR. You know, I'll tell you one thing. I brought in Halifax in the country in 2004. I am the first automated ESR lab in the country. And I'll tell you one thing, I suffered a lot. And I'll tell you one thing, you know, it's not easy. It's not easy. If somebody wants ESR, you need to provide them ESR the way they want ESR.
Yeah.
But, okay, if your customers are not the people who want 20, 40, 60, you are very happy.
Sir,
You're lucky.
Alex, sir, even if somebody comes and asks me tomorrow, we still have Westergren tubes. We still know the technology. Like, sir, you said you have not seen a slide for 7 years, but doesn't mean you have forgotten it.
Dr. Vishu,
So we can always
Dr.
do
Vishu, don't go back to retrograde.
No.
If you want to introduce new technology, you have to explain new technology. Don't go back. Don't go back. If you want to introduce new technology, you should have the courage and the confidence to answer this 20, 40, and 60 fellows. You know,
we can do that for
you
them
know,
in
you
the
must
conventional
realize
method.
that 20, 40, 60 fellows in my hospital are not simple people. They are Maman Chandi. They are all top fellows. They're not simple fellows. So if you say 20, 40 ka khatam, kahani khatam, that's it. Just keep quiet. Don't go back to old technology. Don't go. You know, I do 600 ESRs every day. And I have evaluated, yes, I mean, I have evaluated Halifax. You know, I'm talking about 2005, 6, 5. I've evaluated Halifax. I've evaluated West Cube. And I'm not talking about Westmatic, West Cube. 800, 80, 200. I have evaluated all of them. And I am using a technology which I feel is good. So thing is, 20, 40, 60 is old story, but it's still useful. Don't discard it. Thanks to our seminar that we had today. So 20, 40, 60 is not, don't discard it. But if any technology that comes which can explain 20, 40, 60, we should welcome it with all.
So, thank you.
So that's what I said. 20, 40, 60. If it comes, whether it comes through Mindray, whether it comes through anybody else, we should welcome it. And thanks for your presentation, because, you know, not only he took us to the entire gamut of ESR, because, you know, we are almost forgetting ESR, but also the fact that automation is the way to go. Because, you know, even still there are, you know, if you go to nowadays, you know, all these manufacturers, they say, we should, let's go to tier 2 cities, tier 3 cities, tier 4 cities. HBTC, DC, ESR. ESR is still part of your investigation. You can't automate ESR in those places. You can't automate ESR in those places.
Certainly.
Yeah.
But sir, if you look
and
at
ESR
it,
is the way the ESR is done nowadays, it's so horrible. There is no Westergren. You know, it's put one evacuate fellow, they'll put one tube, you put it in one EDTA tube and take reading.
So that's
only the patient who has got the extreme conditions, he'll benefit.
Sir, except a few institutes or places where they are very focused, right? I don't know if I would be able to manage at 600, but yeah, at 100, 150, they're still manageable. The quality, you may say we are giving 20, 40, 60, but the reliability of the result, the operator dependence, the clinician, we are giving an answer, but when I look into my conscience, I don't know what is my confidence level of the report I have given in the traditional method.
Your confidence level is there.
Sir,
Upar wala.
But sir, likewise,
That's
as
all.
you said in the tier 2, tier 3 cities, sir, but if
No.
we go back to the year 2000, when, or say late 90s, when auto analyzers started coming in, there are a lot of people, I remember I was actually in school then, and people talking to my dad that no, auto analyzer does not do as well as microscopy. Every slide needs microscopy. 10 years later, I heard that, okay, there should be slide reviews criterias. Now, today I met you, you gave a whole new perspective, right? So, and right now in tier 2, 3, wherever there is a CBC being done, it is being done on an autoanalyzer. In last couple of years, till about 5 years ago, it was a 3-part dominated market out in the non-metros. But that is also transitioning to a 5-part differential market now. So yes, today I don't think so. Say let's talk about BC series only. The automated ESR, this one is not well penetrated even in the top labs in the country. It's just a new thing. It's still being evaluated. But let's look down a decade. We are on cube 7, maybe at cube 17 or 20. It may be there in the tier 2, tier 3 cities.
So Vishu, I don't want you to be emotional about ESR.
No, I'm not, sir.
No, I'm telling you, ESR is only a prognostic test. As long as the companies don't convince you that it's got beyond prognostic value, don't listen to them.
Sir, I'll honestly tell you, I'll show you in my laptop. I had a slide that ESR. Okay.
You have showed us a lot of slides.
No. So that
Nitin,
why ESR is still relevant. Why ESR is still relevant in the current scenario.
Yeah.
That was the most important part. Why I said let's not talk.
So
negatively.
as long as only is remaining as prognostic, let's not give too much importance to its accuracy. Okay.
Sir, I'm sorry, sir, but I beg to differ. As long as there is a test which I'm reporting, whether it's prognostic, diagnostic, or random,
it doesn't replace.
It needs the dedication and honesty.
It will not
that
replace.
I cannot blindfold myself.
It will
to
not
fault.
replace Vestergren.
I want to
It will
make
not
one
replace
comment.
Vestergren. It
The
will not replace Vestergren.
The question here, which sir should have actually asked, is automation versus the traditional method. Which
So
can
the
you
thing
go
is,
ahead?
sir, we are not talking about versus,
Huh.
because we are not talking about diagnostic test.
Correct.
It's prognostic. As long as we leave it prognostic, we don't talk about.
So, but in my humble,
which we don't talk about which technology is better or not. We don't talk about technology here. We just say, as long as it can help prognosis, it's fine.
But
so how will
in a symposium, what question we are asking is how do we adapt? How do we adapt technology into our practice? And how is it going to impact?
In the interest of time, maybe
just go by literature. Just go by literature.
during the dinner.
Just go by literature. Just go by literature. That's all. Thank you.
Thank you.
Thank you. Thank you very much, Dr. Sukesh, for your guidance and insights. Thank you, sir. So you have any questions?
Yeah, thank you, Dr. Basin, for your informative and that refreshing basics of ESR. This is widely used test and most important, though non-specific. We will discuss this 20, 40, 60 in dinner with 30, 60, 90. Thank you.
Okay, thank you. That made it light, you know. Okay, thank you so much. May I request Dr. Mohan Galande to please come on stage and felicitate our speaker. And may I request Dr. Mohan, please. May I request Dr. Ramon to please felicitate Dr. Mohan Galande. May I request our last speaker of the day, Dr. Deepika Parwan, to please come on stage. And may I request Dr. Piyush Patnaik to chair the session, please?
Good evening, friends. So we're coming to the last ball of the final over of today. And I think Dr. Deepika Parwan, she is the head of department consultant pathology at Sarodaya Hospital, Faridabad, and lab at a group of hospitals, Anshu group of hospitals. With 13 years of experience in post-MD experience at Lady Hardinge Medical College. It's a pleasure to listen to you and listen to what she's going to talk today on the parts of pathology that she's going to explain to us. Welcome, Dr. Deepika Parwan.
Hi. Good evening. First of all, I would like to thank Mindray and the organizing committee to invite me here. My topic for today is infectious and non-infectious etiology masquerading as cytopenia, role of peripheral smear and bone marrow examination. It's a very small presentation. And as we all know that cytopenia per se is not a disease by itself. It is a common pathway which can be because of many etiologies, which can be infectious, nutritional, neoplastic, non-infectious, etc. Why I have kept this topic for today is why a simple test like peripheral smear is important to diagnose even rare diseases. And it's a very small presentation. I've kept just three cases. Two of them were reported recently by me, and one was reported a few years back, but all of them are interesting. That is why I've kept them for today's presentation. The first case is a patient who came to us. He's a 42-year-old male, a resident of Bharatpur, Rajasthan, teacher by profession. He presented with history of fatigue for the past 1 month, fever for the past 1 month, weight loss, bleeding and from gums and nose for the past 1 day. There was no other significant systemic complaints, no known comorbidities, no addictions, and no family history. On examination, the patient was conscious, oriented, vitals were stable, pallor was there, but there was no icterus, no lymphadenopathy was there. Oral cavity, throat showed no tonsillar enlargement or gum hypertrophy. The positive finding was massive splenomegaly, which was below 10 centimeters below the costal margin. Outside investigations were done, which showed CBC of 7 grams, HB of 7 grams, TLC 2980, and platelet count 23,000. So now we have a patient with pancytopenia and massive splenomegaly. So these were the differentials which were thought of: CML, HCL, myelofibrosis, PV, marginal zone lymphoma, chronic malaria, Kala Azar, etc. Then I got the peripheral smear of the patient to see the case. On further evaluation, patient had CBC of, in our hospital, we again sent the sample for CBC. It was 7.9 grams. TLC was 2,320. DLC showed 19 neutrophils, 70 lymphocytes. RFT, KFT was normal. LDH was normal. In the peripheral smear, this was the picture. So these were the cells which were able to pick up on the peripheral smear. These were cells, large cells, almost 2 times the size of a small mature lymphocyte, having these hairy projections. So based on the morphology, we gave the diagnosis of features are suggestive of hairy cell leukemia, but we advised the patient bone marrow aspiration and biopsy for confirmation of the diagnosis. Bone marrow aspiration and biopsy was done. The aspirate was markedly hemodiluted, as we see in all the cases of hairy cell leukemia because of the extensive marrow fibrosis. The aspirate was diluted, but we were able to appreciate similar cells in the aspirate. In the bone marrow biopsy showed the classical picture of hairy cell leukemia with reticulum fibrosis in presence of these atypical cells with clear cytoplasm, reniform nuclei. So morphological diagnosis of hairy cell leukemia was given. And on flow cytometry also, these atypical cells were positive for CD11C, CD19. They were CD25 positive, CD103 was DIM positive. These were negative for CD5, 10, 23, 38, 43. And on IHC on bone marrow biopsy, again, it showed PAX5 positivity, annexin A1 positivity, and TRAP positivity based on the morphology, IHC, and flow cytometry. The final diagnosis of hairy cell leukemia was given, which was picked up on peripheral smear examination. My next case is So hairy cell leukemia is a rare chronic B-cell malignancy. Median age of presentation is 50 to 60 years. Peripheral smear with bone marrow aspiration and biopsy are very important to reach the diagnosis. My next case is a very interesting case. A young, very beautiful girl, newly married girl, came to our hospital with, she presented with a rash on her forearm, which progressed to a discharging ulcer, for which she underwent local dressing from a nursing home. After a few days, she was admitted to our hospital with history of fever, body aches, headache, decreased oral intake, pain in the lower abdomen, swelling, and discharge from the forearm from the same ulcer since 4 to 5 days. Now, the patient was extremely sick. She was sick. She was having high-grade fever. So the clinician thought that she must be having some kind of acute leukemia. So I received the peripheral blood of the patient to see the smear. He told me, ma'am, please see the smear. And if she has any kind of leukemia, we will transfer the patient to the oncology unit. Even we were suspecting the same. The routine investigations were done, which were normal. The HB was 12.9. TLC was reduced, again, a bicytopenia case. Rapid typhoid, IgM, malaria antigen tests were negative. Biochemistry was almost within normal range. PT was 31.7. INR was 2.69. Then we received the peripheral smear. On the peripheral smear, this is what I could see. The Leishman-stained smears showed heavy parasitemia comprising of flagella, undulating membrane, and the central round nucleus, suggestive of trypanosoma. The sample was sent for further confirmation outside to the central laboratories also, where they confirmed the diagnosis of trypanosoma brucei rhodiense. So then we took the complete history of the patient. Patient had gone to Uganda 10, and she had come back 10 days back only, after which she developed the symptoms. So the initial chancre of the bite of sissy fly was mistaken as ulcer, for which dressing was done. After confirmed diagnosis, patient was treated, and now she is doing well. She is fine. The medicines were imported from Africa, and she was extremely sick with heavy parasitemia, but timely diagnosis saved her, and she is doing fine now. So this case highlights the importance of taking proper travel history from the patient, which in our case was neglected initially, and therefore classical chancre on the forearm of the patient was missed, presenting with the symptoms of fever, headache, abdominal pain, which could have given a probable differential diagnosis of a very rare disease. It also undermines the importance of peripheral blood smear examination. A properly Leishman-stained peripheral smear can sometimes give us a very important diagnosis, which we can miss if the sample is only sent for CBC to a peripheral lab. So she is doing well, and I'm also happy. She's also happy. My case number 3, again an interesting case. A 60-year-old female who was referred to our hospital with a history of pancytopenia. He was evaluated at multiple places as a case of pancytopenia. People were giving her vitamin B12, folate, everything, hematinics. Blood transfusions were given to her repeatedly. But then she was referred to our center. Her chief complaints were fever, body aches, nausea, and malaise since 2 months, which they were relating with some kind of anemia or nutritional deficiency only. Investigations showed HB 6 grams, TLC 2500, platelet count was 40,000. Peripheral smear showed pancytopenia with normocytic normochromic anemia. No abnormal cell, no blasts were seen in the peripheral blood. Ultrasound showed mild splenomegaly. Viral markers were negative. Blood tests for dengue, malaria, and typhoid were negative. So we asked the doctor to send a bone marrow aspirate and biopsy, because we might be missing some aleukemic or subleukemic leukemia. Then this was the bone marrow aspirate smear. Again, to our surprise, this showed increased number of macrophages with presence of yeast forms of histoplasma capsulatum. Serum ferritin and triglycerides were remarkably increased, supporting the bone marrow findings. This is the bone marrow biopsy, which again showed histoplasma capsulatum in the macrophages. GMS and PAS stain were contributory. Further testing, histoplasma urine antigen test was positive, so our diagnosis was confirmed. Patient was treated with amphotericin B and steroids. She has become now febrile and is doing better, still admitted in the hospital. To conclude, this case highlights the importance of bone marrow examination in cases presenting with pancytopenia. Also, awareness of histoplasmosis is important, as this disease is still rare in non-endemic areas of India. has variable clinical course, and its features overlap with those of other systemic illnesses, including tuberculosis and malignancy. Early diagnosis and treatment is vital in otherwise fatal condition. Thank you.
So, thank you, Dr. Deepika. We all, all of us here, most of us know importance of bone marrow examination, but here we are here mainly for peripheral blood examination. So, in your first case, did you have any data on, cell counter data on the hairy cell leukemia?
No, sir.
You don't have. Okay. There are certain features on peripheral blood which can, on the cell counter, whether it is Coulter, whether it is Sysmex, or whether it's Mindray, there are certain nice features which will tell you that this patient has got hairy cell leukemia. So, recently I was reporting a marrow with one of my students, and I have got technicians who have been trained. My technicians are trained differentially, which many of the people who come to my lab from Abbott and Abbott, they understand. So there's a patient with hairy cell leukemia. I look at it. Then I look at the peripheral smear. There is hairy cell leukemia. Nobody has reported the peripheral smear in our lab as hairy cell leukemia. In the marrow only, it's reported as hairy cell leukemia. So I called my technician. I said, Josephine, go and look at the plot, scatter plot. And I continue reporting. After 5 minutes, she comes back. My resident is opposite to me. I'm sitting here. So I said, what do you think? And she said, my technician is telling, hairy cell leukemia. My resident is shocked. My resident is shocked that this girl can make a diagnosis of hairy cell leukemia just from histogram and scatter. And she didn't give a differential diagnosis. She just said hairy cell. So thing is, it's very important to not look at marrow. Sometimes peripheral blood is more important than the marrow.
Yes, definitely.
In your first case, your second case, your first case was hairy cell leukemia, second case was?
Trypanosoma.
Huh?
Trypanosoma.
Trypanosoma. This man has got a patent on it. He has got a patent on it. On hemoparasite. He's got a patent on it. And what is the cell counter you have?
Yes, sir.
Huh?
We have a Mindray.
Mindray. This man has got a patent on hemoparasite in peripheral blood on cell counter. It's not malaria. He says hemoparasite. So, I used his patent to identify LD bodies in peripheral blood. You remember, I had a poster in Las Vegas, LD bodies in peripheral blood. He has got a patent on hemoparasite on peripheral blood on cell counter. So I would have nice to, sometimes, when we are talking about cube, we are talking about cytomorphic unveiling blood evaluation. So please bring data from cell counter. Don't bring cell counter, data from bone marrow or anything like that. Bring cell data from peripheral blood. Because, it's not very easy to get experts like him. It's not easy to get experts like him. So it's good to bring data from cell counters and show the cell counters to him. And maybe he may apply for another patent, and you may be part of the patent, you will get money from it.
Thank you. Okay. No, what I have to say is congratulations for your talk. It was very good. And the cases where we were all of us doing, what will be that? And we were sharing, very nice. But of course, the peripheral blood is, every time we have a case that is like that, it's important maybe to do to collect all the information for the future and for others, if it's possible to see any pattern in the histograms or in the scatter plots, is make it easy because and what the people do is even do a poster to remind the people validating there to hang it in the wall in order to remind the typical pattern for candidas when they are in the blood have also a typical scatter plot that you can suspect the presence of candida. That is all. In addition, something nice to have. But thank you very much because your conference was fantastic.
Thank you, sir.
I'd like to add something to it. What I, as a pathologist, believe, the cell counters or the histograms and the scatterograms that are coming to us should add as a benefit or a support to what the pathologist sees. So my thought process always says that when you're talking of histograms and scatterograms, it would always be better to compare it with what the peripheral smears are going to give us. And it should not be the only diagnosis on the basis of histograms. So I would always suggest that a peripheral smear is what is very much required, because, for a pathologist, once he sees the slide, that it helps it in all ways. Like the diagnosis on the basis of peripheral smear is always better. What you can see on a slide, I don't think you can match that with a histogram.
Absolutely.
Yeah, it is an aid to what you're going to diagnose on the, yeah.
Okay.
Yeah, exactly.
Can I ask you a question? The bone marrow aspirate of the type of leukemia was empty when you tried to aspirate, or you need biopsy?
No, it was hemodiluted, but it was showing us cells. There were cells. That is why we were able to perform flow cytometry on it. It was not a dry tap. It was a dry tap, but it was hemodiluted with the peripheral blood. Even the peripheral blood had 15% cells. So those cells were coming from the blood only. Yes, sir. Yes. Yes. Yes, sir. Yes, sir. Yes. Yes. Thank you, sir.
I would like to mention Dr. Ramon, Dr. Ranjana Havaldar from Sodani, Indore. She's working on scatterplot findings of rare leukemias. So we'll be taking your guidance in that. And recently we have for our case book, we have given that case of Dr. Ranjana Havaldar of a hairy cell leukemia only. How it was diagnosed from a scatter plot and histogram. Thank you. Yeah. So thank you so much, Dr. Deepika. And everybody is waiting for the dinner. And may I request Dr. Piyush Patnaik to felicitate our last speaker of the day. Thank you so much. May I request Dr. Ajay Shah to please come on stage and felicitate our chairperson, please. Thank you. Thank you so much. Thank you so much, our online viewers too. So tomorrow we meet again at 9 a.m. Please come.